So good afternoon to all of you. Myself, Dr. Chirag Verma, Director and Chief Instructor, Academy of Exercise Health and Therapy. Today we are into Gynae Colloquium. That is a part of Second International Web Physio Summit 2021, organized by Academy of Exercise Health and Therapy in collaboration with Assam Downtown University as an academic partner, as well as European Register of Therapists and Osteopro and Osteopathic Organization from Italy, Milan. So today we have this Gynae Colloquium right now from 3 p.m. to 4 p.m. In this, two speakers will be there, Kitty Boni from Bahamas and Dr. K. Ravali from India. They'll be speaking on gynae topics. In the morning session, we had a neuro colloquium, and in the evening, we will be having ortho colloquium. In that, 4 speakers will be there. So for this session, Gynae Colloquium, we'll be having our chairperson, Dr. Megha and Dr. Kapila Jain, as well as our guest, Dr. Vinay Jagga and Dr. Bhavna Puri. So I would like to request Dr. Saurabh to welcome our chairpersons.
Very good afternoon to all. This is Dr. Saurabh from Academy of Exercise Health and Therapy, welcoming you all to this session. Hope we have a great session today morning and we'll continuing it today as well. So welcome you all. Welcome to our guests, speakers, everyone. This will be a great summit for all of you. We'll be sharing the best of knowledge to all of us. And kindly proceed, ma'am. Please kindly proceed your lecture.
Yeah, so Dr.
Participants will be waiting.
Yeah. So Dr. Kitty Boni is from Bahamas and is a PT DPT working in his own clinic. And today he'll be taking the topic effect of cancer treatment effect on women health. So Kitty, you can start. Kitty, unmute yourself.
I'm muted.
Yeah.
So good afternoon to you guys. It's a pleasure to be here and to present to you. Like Dr. Chirag said, I am a physiotherapist in the Bahamas. I've been a physiotherapist for 21 years. I currently serve as the chair for North America and Caribbean region for World Physiotherapy. I have been a therapist dedicated to oncology rehab for the last 17 years. I got into it because I was seeing a lot of patients in the hospital. I was a private physical therapist in a private hospital that were presenting with swelling, and it wasn't responding the way that we needed it to respond. And so what I decided to do was go in and further my education in 2004 in getting a certification in lymphedema management. By default, I was getting a lot of patients that had oncology diagnosis with lymphedema, and they presented with other side effects. And so I had to keep learning and delving deeper into oncology rehab. So I've spent quite a few years there, and I'm honored to share what I have. I'm very passionate about it. So the objectives, we'll talk about the incidence of cancer and survivorship. We'll discuss the cancer treatments and side effects, survivorship impairments in cancer survivors, the role of physiotherapists, and this was what I really want to drive home today, and discuss outcome measures and discuss treatments for it. So we know that statistics have shown that cancer is here to stay and it's growing. We're trying to do all we can to educate people on prevention of it, but it seems to be trending higher. Globally, we're seeing 1 in 5 people. When I looked at the statistics in India, it was 1 in 9. So you guys are trending behind. But what's most important today is that we look at the incidence in cancer in men versus women. Globally, women lead, and in India, it seems that they're leading as well. And so it's very important that we give this the attention that it needs. Oncology is a very underserved population, and in physio and in rehab. And we'll talk a little bit about that more. So when we talk about the survivor, we're talking about somebody that's been diagnosed immediately. Once you get the diagnosis of cancer, you're considered a survivor. So we go into full stream. We understand that there's a sequelae of events that will happen, and it's very taxing, not just physically, but psychosocially, and as well as economically. Unfortunately, I don't think most physiotherapists are in the position to help economically, but definitely psychosocially and physically, we can meet that mark. And we should be encouraged to have that conversation and step out of the realm of just thinking very clinical or just treating the impairment, but treating the person as a whole holistically. I saw this and I just thought this is so pertinent for today. Let's not forget that in India, the symbol of strength is a woman. And I know we come from different cultures, but the woman is the mother, she's the homemaker. And if she's not strong, the family, the house would not be strong, the home will not be strong. So we have to ensure that when we come across these women who are survivors, that we do whatever we can to fortify them, strengthen them, and give them back the dignity and quality of life they need to be that strength of India. So we talk about the different therapies that a survivor would be exposed to, and we talk about the side effects of it. I'm not sure, we don't use a lot of biological treatments in the Bahamas, although it's growing worldwide, and I'm not sure what your access or your usages in India, but it's important that we pay attention to these things because we need to be able to identify and also have an idea of what we expect to see when we come across a survivor in our clinics. Now, if we're saying that 1 in 5 or 1 in 9 may develop cancer, we're looking at people walking into our clinics as cancer survivors. And are we usually asking this question, are you a cancer survivor? And are we trying to find any impairments that they may have? Because sometimes they may come to us for something that may be orthopedically aligned, but we didn't have that conversation. So knowing these treatments and understanding what their side effects and impairments can be is very important to us moving forward. So with chemotherapy, people tend to know that right off the back. They think about losing their hair, losing weight, but are you considering the neurological changes that happens, right? Because chemotherapy is taking care of the cancer cells, attacking it, but it also attacks healthy cells. And so those healthy cells will include your nerves, it will include your muscle tissue. And so what we see is neuropathies. We see a lot of chronic fatigue. There's pain involved, sexual changes, bowel and bladder changes. And this is why it's so pertinent to a woman, because we don't have these conversations enough. Our patients don't feel comfortable about talking about their lady parts, their vagina, their bladder, their bowel. And even in cultures or countries where it's just a bit more open and a bit more exposed, we still have challenges bringing this conversation to the forefront. And when you have a patient that has had chemotherapy, these are the things that we need to bear in mind moving forward. When we talk about hormone therapy, we're talking about things that we would see in terms of bloating and breast tenderness and swelling in acute parts. So anytime you see swelling, I get really excited because that's what I really love to do. I love to move the fluid and get rid of that lymphedema. The feeling sick, the leg cramps, the headaches, indigestion. Again, we have vaginal bleeding. For surgery, depending on where the cancer is, what tissues are removed can have long-term debilitating effects. So if we're talking about, well, I see a lot of breast cancer patients, you remove the breast, that's an issue, right? You have to deal with the amputation, the mastectomy of that. But if this is a woman that has had a gynae cancer, you're removing cervical tissue, uterine tissue, sometimes you can have vaginal tissue, and you remove these tissues, we expect to see damages to the area, scarring, sexual dysfunction, and that can be arousal, that can be sexual performance. And it's hard if you have a woman that's in her prime, maybe between the ages of 20 to 50, 60 that has had a viable sex life, and all of a sudden now there's been some alteration in the structure, and she can't perform, or she's is experienced dysmorphia where she's not comfortable with the way the body looks. That can be very psychosocially damaging to the woman, and we need to have those conversations and ask if that is an issue. Pain and infection, slow to recover in other body functions, all of these things can occur from surgery. We don't talk often enough about wounds because wounds can be very chronic and long lasting depending on the surgery, and especially if it's followed up with some other treatment that may impair healing. We talk about radiation with our patients, right? If there is radiation in the pelvic region, you can have skin irritation and swelling, you have hair loss, you have bladder irritation, so you can end up with frequency and urgency changes in the tone of the bladder musculature. Again, radiation brings a lot of fatigue. If a woman's not has the energy, she fatigued, she won't have the energy to perform activities of daily living and any other task over that. There can be nausea and vomiting. These are usually acute, but some people can complain about that long after, especially if it was in the lower abdomen region. Mouth changes, sexual changes, like I mentioned before, urinary problems. The thing is with radiation, though, I have a colleague who had radiation at 17. She was a non-Hodgkin's lymphoma survivor. She's in her 60s, and she says radiation is the gift that keeps on giving, because even at close to 50 years after her initial treatment, she's still experiencing tightening of the tissue, fibrosis of the tissue. So understanding that this can happen anywhere in the body, if the woman is exposed to radiation in her pelvic region, one can expect to see those changes in the vaginal tissue, in the pelvic floor tissue, and that can produce pain and bladder irritation and joint problems as well for the hip, if the hip joint's involved, and that can severely impair her function. The other thing that we have to talk about is infertility. We see cancer manifesting earlier on in life. So before, cancer was more or less of an older person's disease, where we expected people cancer manifested in their 40s, 50s, and 60s. But now we're seeing cancer coming in with people in their 20s and in their 30s. And this is prime childbearing years. And if somebody has cancer in that pelvic floor region or the pelvic region, lower abdomen region, now we're definitely lessening their chances to have good reproductive health, because of course the reproductive organs are in that area. So radiation and surgery in those areas could definitely compromise or decrease a woman's chance for childbearing, and that in itself is another issue for that. We can also have prolonged damage to the bowels, which can lead to diarrhea and bleeding, and that's another challenge, because you're talking about dignity, you're talking about freedom of movement, and lymphedema, because the lymph nodes are in that area, the inguinal area, the abdominal area. And radiation has a very drying sort of, it literally makes the lymph nodes shrink and become dysfunctional. So the person is not able to move lymph through the body like they're supposed to. And then you're going to have this abnormal accumulation of fluid, which is lymphatic, which is lymphedema, and that can be challenging. That's one of the things that I saw as a young therapist in the clinics, in the hospitals, that there would be women with uterine cancer and cervical cancer, and they're sitting there severely swollen, and nobody knows what to do. And the swelling is just concentrated in the upper thighs or in the abdomen region. And we need to have the awareness and the skill sets, or at least the ability to refer and know who to refer to when you see these people early, for early intervention and early treatment. Moving to the next. So sort of went through those quickly because I wanted to spend just a bit more time talking about it. we have a lot more cancer survivors now than we used to have 10, 15 years ago. And what that means for us is that these are people with impairments that are aging. So we already have impairments that come along with aging. We have impairments that come along with lack of physical activity. And then we throw a cancer diagnosis and cancer treatment on top of that, and we can understand just how complex these patients can be. And so it's very important that, again, we have the conversation. You'll hear me say that over and over again, because treating this population, frequently when I get a new patient, the patient would say to me, but nobody asked me that question. Nobody asked me how I was having sex. Nobody asked me if my urine was flowing properly. Nobody asked me about if my bowels worked. And they feel very cheated and they feel very neglected. They also carry a lot of guilt because these women do not want to complain. They don't want to feel like they're being a burden, like they're being nagging to the physician or the oncologist. And I always, as a physiotherapist and a physiotherapist that specializes in oncology, and I tell them that this is the place that you get to complain. This is the place where you get to have the conversations that you want to have with your medical doctor. And I'll be able to relay that to them and meet, hopefully, the needs that you have. So you will always hear me say, have the conversation. I am a very holistic therapist. I believe in the holistic approach. So it's just not what I see physically. We always talk about the psychosocial component and the emotional component of it. And that needs to be fortified as well, because we're working on the body, but if we're not giving the person the chance to come in, and especially when your sexuality is tied to it, we really need to give that the attention that it deserves. So as we review again, the other things that can present, the physical impairments that we would see is the cancer-related fatigue and overall deconditioning. I'd like to put fall risks in here because we see in high incidence in falls. And that's because you may have the neuropathy in the feet, you may have weakness in the muscles, and definitely the fatigue, the lack of energy. And the falls are scary, especially when you're osteoporotic because of cancer treatments, right? So we need to make sure we're doing enough to talk about that. Sometimes we ask for bone density scans, and it's very good to have it in the pelvic region, especially after radiation. Looking for lymphedema, looking for radiation and fibrosis. Again, the changes in the skin, the hardening, the scarring, the lack of mobility that can cause pain, that can cause lymphedema, that can cause body issues. I mentioned the neuropathy, urinary and fecal incontinence, obstructive voiding and defecation, muscle spasms and muscle overactivity, muscle weakness, and that's in the pelvic floor. The muscle spasms and the muscle overactivity can be in the pelvic floor as well, which makes sex uncomfortable and painful many times, or sometimes even impossible. You can have the muscle weakness and fatigue, pelvic pain, sexual dysfunction. Men see it as erectile dysfunction, but for women, it's that pain. It's that pain that we can't deal with. It can be vaginal atrophy of the muscles as well. And then this whole psychological, again, there's a whole psychological distress from dealing with all of these, trying to be wife, mother, employee, and trying to be that survivor and healing whole. So again, it's what we see. We treat the physical impairments, we prevent and minimize disability, we assist with wellness and quality of life, and we reduce the risk of getting cancer and cancer prevention. And we, again, have those conversations. Now, I am not a pelvic floor physiotherapist. I will tell you that right off the bat. I do some interventions in terms of myofascial release. If there is a lot of tone, we teach patients how to do it on themselves, the release on themselves, but I definitely refer. I have 2 colleagues in the Bahamas that are fantastic with pelvic floor. So I do my due diligence with screening and asking those questions, and I definitely refer. And it's very important for us to know when to refer, because for most of us physiotherapists, we get a brush over in school, in university, or our training programs. And whilst we may be equipped with a few skills, like I said, early intervention, early detection and early intervention really sets the tone and would probably define how this woman's quality of life would be. And so, as I said, if you identify these things, the pelvic floor dysfunction, if they talk about pain, difficulty having sex, difficulty with penetration, they're talking about the vagina is changing shape or feels different in terms of tone. If they're complaining about bowel dysfunction, again, that's constipation, sphincter tightening, bladder dysfunction, sexual dysfunction, vaginal atrophy, pelvic pain, find that pelvic floor therapist in your area and refer. So again, we need to have the conversation. I will say that because of the aging population, number one, you're going to have changes due to aging, because women, as we hit 40, 45, 50, we start to go through menopause. So you will see those hormonal changes taking place. You will see the atrophies, you will see the hot flashes, you would see the drop in libido already in the natural aging process. Then you may have a person that had diabetes before they were diagnosed with cancer. So that's another comorbidity superimposed, or hypertension superimposed, and then you have the cancer diagnosis. So we can be dealing with very complex, very involved individuals. And then we have to pay attention to the person's mental state, or mental wellness, I should say, not state. Depression and anxiety, of course, have to be diagnosed, but one can see trends towards it. And having the ability to identify and have that conversation, because usually with depression and anxiety, these patients are unmotivated, and they're probably going to be not very compliant with our plan of care. So if we don't address the mental wellness aspect of it, we're probably going to have a patient that's not going to do as well as they could do as we do our plan of care, and struggling with maintaining a thriving home. And this, again, being very holistic, finding out what is the family structure like, what is the support level like, having that conversation. Because yes, we're talking about a cancer diagnosis, and yes, we're talking about pelvic floor dysfunction and impairments, but this person has to exist in an environment. And again, we need to understand how she's functioning, how she's being received, what are the relationships like, because all of that aids with how our survivor is going to not just survive, but thrive. So we assess the clinical practice guidelines. There's some fantastic guidelines out there. And we want to be very comprehensive in our care. I think more and more now, physiotherapists are being recognized as that holistic practitioner. In terms of healthcare, we're probably the clinicians that spend the most time with our patients. Questions that they would forget to ask their oncologists and talk about, and it's usually the more sensitive sexual pelvic floor questions. They're going to have that conversation with us. And so we have to be able to have those honest conversations with them, and honest conversations with our physicians as well. So we're the liaison between the two, and we need to be very open to that, and create a safe space for them to help them heal. So again, our role, we know what we do. We treat what we see, we improve functional impairments, we get rid of the disability, but we can diagnose and we can treat the physical, the psychological, and the cognitive impairments, because we did talk about I don't think I mentioned it, but with chemotherapy, you can have what we call chemo brain, where there's memory loss. And again, if we're having a patient do certain exercises, like maybe avoiding log for bladder and bowel function, if they're having challenges in remembering, we're not going to have a successful logging. And so again, we have to be comprehensive with our questions and ask the right questions, and just make sure we keep that space open for these people. Again, we're mentioning that it's an aging population. We are seeing younger survivors, but bearing in mind that survivors are probably going to be more towards the 60s. But not only that, if we have a survivor that comes in that's diagnosed in the 20s and 30s, you now have all of these impairments and dysfunctions that can follow them into their older age. So we have to be very aggressive with treating and correcting any issues that we see so that they may have a better quality of life as they age. And it's all about quality of life, all about quality of life. So I will just repeat again, have that conversation, ask those questions, be comfortable with screening. I've put a few outcome measures down here. It's a distress thermometer, what they use in the National Cancer Center. And this is what it looks like, the National Comprehensive Cancer Network. And it's asking questions. And when we talk about being holistic, we can just jump right here, right, to the physical problems, because that's what we do as physiotherapists, right, the physical aspect of it. But bearing in mind that you're dealing with somebody that has other components that's going to affect their wellness. And so we want to ask, how are they functioning at home, right? How are you dealing with your relationships? Emotionally, how do you feel? And the great thing about this is that identifying this, then we now know probably who we need to refer that person to. And it's very important that we recognize that there's a team approach. So we need to have a good pelvic floor physiotherapist. Yes, we probably need to have a good vestibular therapist, maybe a neurophysiotherapist. But we also should have some counselors on hand, whether it's a psychologist or whether it's a social worker. We definitely want to have maybe a good nutritionist on hand if we're having bladder and bowel functions. Nutrition is very important to making sure that we have optimum bowel function, high fiber, maybe changing the quality of food. We have occupational therapists, we have art and recreational therapists. So we're part of a team, and looking at the stress thermometer, you can see where you can probably refer patients out for these things, and definitely get your occupational therapist involved with memory and concentration. Like I said, your nutritionist, and maybe even a sex therapist, because if we fix the physical problem, there's still that psychosocial component to it that we may need intervention with. The next outcome to measure tool that we can use is what we call the patient-specific functional scale. And it's just asking them, what do you have challenges with? So if we see incontinence pop up here, we know that's probably the referral for the pelvic floor therapist. If there's numbness, if there's tingling, if there's cognitive issues, lack of memory, we would probably see that here as well. And it's giving them the opportunity to tell us what the problem is and be very free and very open to have that discussion. Then we have the fatigue scale, and fatigue is very important because we can't get them to do anything if they don't have the energy. So we need to have that idea of where they're at and then design our programs to deal with that. Depression and anxiety are sometimes are correlated with fatigue. And so understanding that and managing that would definitely give us better outcomes as we go ahead and treat these patients. So there is a need for more cancer rehab professionals. And again, the team approach is very important to us. There's a rapidly growing population of survivors, and we need to make sure that we give them good quality of life, patient-centered care, and again, the holistic approach. So the call of action, I'm going to leave you with these. One, create a safe space wherever you are, whether you're in a hospital setting or in your private clinics, if you're a student, if you're retired, just create that safe space. Sometimes your social media posts can do a lot to spur a conversation and have people thinking. If you are interested in treating cancer survivors, and we said 1 in 5 or 1 in 9 maybe, so you have to be prepared that you're going to get a cancer survivor in there, put that on your flyer. Let them know that you see cancer patients, even if it's just to let them know that this is a safe space and you can have this conversation. Commit to asking the questions. Are you having pelvic floor challenges? What other challenges are you having besides the neuropathy and the numbness and the weakness? Have those conversations. Don't be afraid to delve into those conversations. Utilize your outcome measures, the ones that I've shown. build your network, find mentors. When I started out, I was in the Bahamas. I was the only one that was delving into cancer rehab. It was hard. So thankfully we had the web. I could go out there, I could look for people, I could research, I could find out who was speaking the language that I wanted to speak, and not literally, but who was able to communicate and bring and meet the needs of the patients. And I found that I've had fantastic mentors in Dr. Lisa Van Hoos, Dr. Jill Blinkley, Cindy Falser. These are prominent occupation oncology physiotherapists in the American Physical Therapy Association. And this is what you do. You have these conversations. What's happening here today is fantastic because you're building capacity now. You're building your network. Definitely look for social media groups. Keep learning. Physiopedia is available, fantastic knowledge base. The American Physical Therapy Association of Oncology has a fantastic base. I'm also a certified oncology rehab physiotherapist with Pink and Steel with Lou James, based in New Zealand. So I consider myself pretty international. I will go anywhere to get the information that I need. So I encourage you to do that. And so these are some of the references. And these are my contacts. Thank you so much for giving me the opportunity to present. I hope that I have stimulated and encouraged at least one person listening to really delve into oncology rehab more, because it's a growing population that's underserved and they need us. Thank you so much for the opportunity to present.
Thank you so much, Kitty, for the wonderful session. Please unmute yourself, Kitty.
You're welcome.
Yeah.
It was a pleasure.
If any, Dr. Megha, if you want to ask any question.
Thank you, Dr. Kitty. The deliberations delivered by you were very knowledgeable, and I hope they will help our colleagues in improving their clinical skills. Thank you so much.
You're welcome. Thank you for having me.
Yeah, thank you. It's a pleasure having you here.
If any of the participants wants to ask any question from Dr. Kitty, so they can write over there in chat box. Yeah, actually, Kitty, this we have the streaming over there. It will take 15 seconds to deliver my message to participants.
That is fine. That is fine.
Yeah, and our next speaker is Dr. K. Rawali, PT. She'll be speaking on a topic, pregnancy pain, pelvic pain in pregnancy. Let us wait for a few more seconds. If anybody wants to ask any question, they can ask over there. From Bahamas to India.
And please know that I will be a resource. I guess I can consider myself a mentor, and definitely if we ever need to go back into treatment of fibrosis or lymphedema or any of the things I mentioned, I am definitely available, and I'd love to collaborate and work, because like I said, we need more physiotherapists to serve this population.
Sure, sure. No issues for that. Okay, I think no questions from the participant. Our next speaker is Dr. K. Rawali, PT, and I'll introduce her. She is MPT sports and internationally certified childbirth educator, as well as a pelvic floor rehab specialist, and she is certified as specialist in postnatal core and DRAM rehabilitation. Her designation is in charge physiotherapist and women wellness rehab specialist in Sri Sri Kara Hospital and providing services as women health physical therapist and childbirth consultancy in Basnath Sahani.
Thank you, sir.
You're more than welcome, ma'am.
I'll start sharing the screen. Very good afternoon to one and all. I'm Dr. Ravli. With my interest in women's health, I've started practicing in women's health since 7 years. So today I'm going to talk about the pelvic pain in pregnancy. So this is also known with many terms. Pelvic girdle pain in pregnancy is known with many other terms like pelvic insufficiency, pelvic instability, and symphysis pubis dysfunction. So many other terms are being used commonly to describe this pelvic girdle pain or pelvic pains in pregnancy. Pelvic girdle pain is one of the most common condition in pregnancy that causes significant physical disability, and it has an important psychosocial impact on the pregnant women and their families. But what happens is like usually most of them are commonly in pregnancies they get even low back aches and pelvic pains which are which diagnosis is little bit difficult to differentiate from one another. So it is often underreported and is poorly managed by the obstetrics and their caregivers. So this can result in poorer outcomes and reduced quality of life, and chronic pain would be there in the woman postpartum. So it is important for a physiotherapist to have an awareness about the pelvic girdle pain and also educate the women regarding the pelvic girdle pain, especially the pregnant women. So normally, if you the pelvic girdle pains are mainly related to SI joint and pubic symphysis dysfunction. So the pubic symphysis, now let us see what all dysfunctions we can see in pubic symphysis. So as you all know, pubic symphysis, it is usually normally widens during the pregnancy, and in biomechanically 1 mm of movement is being possible at the pelvic girdle, and 2 mm is possible at the pelvic girdle, and 1 mm rotation, 1 degree rotation is being possible at this joint at the pubic symphysis. So usually what happens, there will be a gap of 4 to 5 mm width during the pregnancy, and it will still widen to 2 to 3 mm during the last trimester of the pregnancy. This is necessary in order to facilitate the delivery of the baby. So at this period, usually the ligaments and muscles are all relaxed because of effect of the hormonal changes, especially the relaxin hormone. So this will result in little instability in pelvic girdle. So let us talk deeply about it now. So first, let me tell you what dysfunctions are present in pubic symphysis. Usually the vertical dysfunctions and anterior-posterior dysfunctions are present in pelvic girdle. Vertical shears are more common, and they are minor, so they are easily corrected. But the anterior-posterior shear forces dysfunctions are little rare, though rare, they cause severe pain and disability. So usually what everyone thinks is because of overstretching of the muscles and relaxed ligaments, that occur because of the hormonal changes during pregnancy, that causes to the that is the reason for the pain, pelvic girdle pains. But the role of hormonal effect is still unclear from the research point of view, because studies have been done in pregnant women as well as till postpartum 6th week, where they have found out that the pelvic girdle pains are not related to either with the joint lax with the they have seen there is no correlation in people who have joint laxity and who doesn't have. So so it is not correct like all the time to think that it is only the joint laxity that is causing the pelvic girdle pains. So other thing what we have to consider is also if this joint laxity is not being supported by the neuromotor control, then that can also result the pain. So there is one more point which you need to consider other than the joint laxity. So neuromotor control should also be taken into the account. Other than this, the postural changes which usually happen in the pregnancy, that could also be a factor which leads to muscle imbalances. So when it comes to the SI joint, it could be one-sided sacroiliac syndrome or two-sided sacroiliac syndrome. That is, the patient might have only the symptoms at one SI joint, which could have been affected, or it could be involved in both the sides too. So usually in SI joint, we usually have the innominate dysfunctions, AIR, anterior innominate rotations, posterior innominate rotations, outflare, inflare, such kind of dysfunctions we get to see. So what would be the symptoms? Symptoms are usually the pain will be experienced at the posterior iliac crest and also at the gluteal folds, and it can also happen at the perineum, and this could also be radiating posterior to the thigh. Below the calf, the radiating pain will not be there in these pelvic girdle dysfunctions, and this would be there till thigh only. And pelvic girdle pains has an incidence of 20% in pregnant population, and it may occur anytime in pregnancy, but however usually it starts in the 18th week of the pregnancy, and incidence being more higher in second trimester rather than other trimesters. And also in symptoms you can see that mainly the pain arises with the activities, functional activities, mainly like walking, stair climbing, rolling from the bed. So with these mechanical stimuli, the symptoms arise. So when it comes to the biomechanical reasons, as I already told you, the instability of pelvic girdle would be one reason, but you shouldn't consider only the joint laxity is being the cause for that instability, and even there could be the poor motor control also, which could also lead to this dysfunctions. So now let us see what are those. Form closure is the stability within the pelvic mechanism, and this will not need any extra forces to maintain the stable state of the system. So usually the articular surfaces and the wedge-shaped sacrum, which is there, this will result in the friction coefficient, and which if they have more of grooves and ridges on them, this would increase more friction coefficient, and thus this will keep the SI joint more stable. So form closure, the stability, this comes within because of the shape of the bone, articular surfaces. And force closure is nothing but these are the external outside forces which are needed to stabilize the joint. What are these outside forces? These outside forces mainly comes from the ligaments, muscles, and neuromotor control, myofascial systems, gravity. All these would come under the force closure. So this is one of the most important thing which we have to know as a physiotherapist, because we are the people who would be correcting the things related to force closure in maintaining the stability of the joint. Muscles involved in self-locking system. So let us see. So in posterior oblique, the latissimus dorsi and contralateral gluteus maximus and biceps femoris, they work together as a synergist to stabilize the SI joint. These are connected to connected to ST ligament. So because of its relation to it, that is how they would create the compressive forces on the SI joint and thus help in stabilizing the joint more. And if you see in the longitudinal sling, multifidus, deep layer of thoracolumbar fascia and long head of biceps, these all get attached to have attachments with the sacrum, and that is how the contraction of this sacral part of multifidus will cause the SI joint to nutate. What does this do in turn? This will create a tension in interosseous and short dorsal ligaments, sacroiliac ligaments, and thus creates the force closure of SI joint. So that is how they are responsible for the stability of the joint. And even the thoracolumbar fascia, which will help in get inflated by contraction of multifidus. This will increase the tension on the fascia, which in turn will increase the force closure. So when you are treating, you have to have this biomechanical aspect in your mind so that you will know the muscle imbalances and correct those muscle imbalances. And anterior oblique, if you see the obliques muscle and the transverse abdominis, these muscles, they connect to rectus sheath, and these when contract, what they do is they give compressive forces on the pelvic girdle, and this will be just like the abdominal binder which we use externally. The same effect this will be given when these muscle contracts, and that is how they help in stabilizing the both the pelvic girdle joints. So now after once the patient comes to you, what you have to do in the assessment, in history and medical history, you have to know if there is any previous low backache. So before she had any low backache, that history you have to take, and also note whether any trauma before the pregnancy. And you should also be knowing whether this pregnancy she's carrying any twins or triplets, because that could also be one of the reason, and also any higher workload during the time of pregnancy. So these things should be considered in the medical history. And then social history, you have to know what are her occupational demands. So you have to know whether she has, like for example, if it is an IT professional, they need to sit for long hours, so long sitting, that is also one of the cause for this pain. So occupational demands and her functional activities should be noted in social history. And pain, while taking the pain history, you have to just note down the pain points in the pain chart. Usually you would be seeing the pain in posterior side, mainly at one side of the back, low back, where it could be at the PSIS and also into the gluteal region. And also there could be radiating pain. If at all it is there, it will be till thigh. So apart from this, the nature of the pain, it could be stabbing or catching kind of pain, which the patient would be explaining you. And even the aggravating factors you have to see. So if you see, it could be like aggravating factors would be prolonged sitting and the stair climbing, repetitive stair climbing, and prolonged walkings, rolling over the bed. All these would increase the pain. So along with the history, you have to check out for any red flags also, because it is very important to differentiate whether it is a pelvic girdle pain or it has something else underlying disease. So if there is a pain in absence of mechanical stimuli, like as I told, like rolling over the bed, or only those times the patient would be feeling the pain. If if the pain symptoms are reduced while they are lying down, inside lying or hook lying, then that could be mostly the pelvic girdle pain. But if not, even the pain is present in absence of this mechanical stimuli and even on resting, then there could be unexplained, then you can put them under the red flag. And weight loss, you have to check for any unexplained weight loss, neurological symptoms, and any incontinence, bowel or bladder dysfunction, significant trauma history, and vaginal bleeding. So all these could be flags. Okay. On observation, the gait, usually it will be antalgic when you observe, and even the pelvic mobility is increased in both sagittal and transverse plane in gait. And functions, as I told you, functions like in ADLs, you have to see whether she is bracing. Like while usually what happens when you ask the patient from sit to stand, come from sitting to standing position, that time they would go for bracing. So that all you have to observe. And posture also, when you are observing posture, see whether she is able to stand for a long time. If she is standing, is she shifting the weight, continuously changing the positions, and is she standing on one side only? All these you have to observe, because this will give you a picture of whether any muscle imbalances are there or not. So palpation, usually you would be palpating the PSIs and also sacrotuberous ligament, and sacrotuberous ligament you can palpate, and also the pubic symphysis, which would be tender. Pubic symphysis may or may not be tender, but sacrotuberous ligament and PSIS would be normally tender. So after that, as I already told you, like muscle performances, you have to check for, because this is a one thing which if the patient has poor force closure, you will come to know when you check for the muscle performance. And muscle performance doesn't only mean with the strength. You should also see whether any muscles are tight. Usually here the muscles which I have mentioned, like pelvic floor muscles, gluteus maximus, medius, transverse abdominis and obliques, these all go for weakness. And other muscles which might be tight, like hamstrings, piriformis and calf, all these should also be checked for, because these could also lead to instability in SI joint. So even hip adductors need to be checked, because in many studies they have seen a strong correlation between the hip adduction strength and the pubic symphysis dysfunctions. So now coming to clinical special tests, see after you observe, take the history and palpate and see, you need to confirm it by the clinical special test. The tests which I have mentioned here have the highest sensitivity and specificity. 3 are for SI joint and 2 others I have mentioned for the pubic symphysis. But there are many other tests in SI joint which has higher sensitivity and specificity, but these three are particularly being performed in pregnant women. Okay, so if you are seeing any pregnant woman for the pelvic girdle pains, then you have to go for this test. So these are posterior pelvic provocation tests, also be called as thigh thrust test, and Patrick's-Weber testing Menel sign. So posterior pelvic provocation test, what you will be doing is patient in supine lying, the other leg will be straight. The leg you are testing will be taken to flexion of the hip, 90 degrees flexion of the hip, and with one hand you would be giving the posterior thrust, and other hand would be stabilizing the pelvis. Here in picture it is not shown, but other hand would be stabilizing the ASIs. Okay, so the downward thrust, what happens when you do that, the pain would be deep, patient would complain of deep gluteal pain. So that would indicate the test is positive. And this is Patrick's-Weber's test, where you patient will be lying in supine, and you would be flexing the knee first and then abducting and then external rotate, so that the leg would be placed on the knee of other leg, and you would be slowly stabilize with other hand at the ASIS, and slowly applying a downward pressure on the knee of tested joint. So that time again the compression of SI joint, and you would be knowing the patient, the test is positive if patient feels the pain in the low back at the sacrum. So you can see here, firstly you will be flexing and then abducting and then external rotate and place the leg on the femur of other leg. So examiner is trying to push it down and stabilizing other side. And this is Menel sign, where the patient will be in supine and therapist will be moving the leg to 30 degrees of abduction and then 10 degrees of flexion at the hip, and he will push and pull the leg out of the pelvis, resulting in sagittal movement. And test will be positive if the pain is experienced in SI joint. So you can see the video here, abducted to 30 degrees and flexed to 10 degrees. And now the therapist will push and pull the leg into and out of the pelvis. And the next two tests are for the symphysis pubis, palpation of symphysis pubis, and modified Trendelenburg test. So palpation of symphysis pubis, you would be just making the patient lie in supine and therapist will palpate the pubic symphysis. Test is positive if the patient feels the pain for more than 5 seconds once the therapist removes his hands. That is, once you palpate and leave, if the pain is there for the patient for more than 5 seconds, once you remove your hand, he should feel the pain more than 5 seconds, then only it is positive. And modified Trendelenburg, here the patient will be standing on one leg where the other leg is flexed to 90 degrees at hip and knee. So this is considered to be positive if the pain is experienced at the pubic symphysis. So here is the video for this. Okay, if the patient experiences the pain at the pubic symphysis, then it is considered to be positive. So what are the treatment options? So pelvic belts can be given in severe cases. where the patient will not be able to do even exercises. So for that time, pelvic belts are given, and therapeutic exercises, muscle energy techniques, joint mobilizations in pregnancy is usually been like, you need to be take care when you wanted to do. Usually in pregnancy, joint mobilizations are avoided because the joints are already lax. So only safe manual techniques to be used during the pregnancy, but the joint mobilization is one of the treatment line if you're not using in the pregnant woman. Then modalities, deep heating modalities and electrical stimulation should not be used. They are contraindicated in pregnancy. Icing is the best thing which you can suggest to the patient. And education. So the National Health Medical Research Council has given few antenatal care guidelines. You can prevent the pelvic pains in pregnancies by telling them one is how you can prevent them is they can visit to a physiotherapy doctor either for the pregnancy fitness or whenever they have in the starting stage of the pain only, for the suggestions, advices from the physiotherapist, and ask them to wear low heels in order to prevent more stresses on the sacrum, and avoid more on single leg stands, that is shifting weight onto one side and standing more on that side. All those activities should be avoided. Repetitive climbing of stairs, you have to ask them to minimize the number of times they climbed it. And while getting down from the car, few of the movements which require more of abduction of the legs, those should be avoided. One example for this is getting down from the car. When they are getting down from the car, you can advise them to keep the legs together, knees together, and then get down in order to minimize the stress. And also ask them to apply heat pack for the relief. And education is one of the most important part of the management, where many studies have seen that education along with the exercises, education has worked out more rather than only exercises. Education and exercises have been more successful treatments in pelvic girdle pains. So patient first, he need to be educated regarding the basic nature of this condition, and you have to discuss with them about the relevant ergonomics at the work and as well as home ADLs. As I told you, like you can ask them to minimize the number of times they climb the stairs, and also like single leg stands, avoiding to stand more time on one leg. So all such things need to be educated, and avoiding wearing the heels, high heels. So therapeutic exercises, always keep in mind that after 4th month, the pregnant woman should not be made lie in supine for more time. If you are giving them some exercises, see that you repetitively change the postures, and every time see that they are done in upright or semi-reclined position. If you are giving some exercise in supine, see that not more than 3 minutes it is for. So that is how you have to plan when you are suggesting some exercises. And as I told you, you need to address the muscle imbalances, and accordingly you have to design the exercise protocol. Monticone et al. Used the specific exercise and postural education for treatment of SI joint dysfunctions, and the patient showed a positive improvement in pain at several positions, implying successful interventions. As I told you before, that education and postural education and exercises has given good results rather than only exercise. It's not only postural education, general education about the nature of the dysfunction, about the condition. So these are the few examples which we can modify rather than giving in lying about the pelvic floor exercises or pelvic tilts. So you can make them do in standing and sitting also. So these are few examples where I have given. One is for the gluteus medius activation, multifidus activation, and transverse abdominis activation. Transverse abdominis activation can also be done in sitting or standing too, if you don't want to give it in lying. As I told you, see, it should not be more than 3 minutes because there could be vena cava compression. And this is one for the latissimus dorsi. So pelvic belts, these are the these can be used in severe cases, and non-elastic belts have been shown to be more effective in majority of the women with pelvic girdle pains. One more technique which we can use, especially this I have taken for the pubic symphysis dysfunctions. This works very well, where you are giving the active inhibition to adductors group by giving isometric contractions to abductors. So here the therapist is giving isometric contraction to abductors. This is mainly works on the reciprocal inhibition, as I told you. You would be asking the patient to do maximal contraction first, and then after checking with the maximal contraction, you would say to the patient that just to use 20% of that maximal contraction now with the next repetitions, and ask her, and in the same way you would be slowly going to little outer range also in the same. After this isometric contraction, what immediately the therapist have to do the isotonic contractions for adductor muscles. So here the therapist has used only one hand for both the legs, where you would be asking patient to contract against the patient hand. So this is one muscle energy technique which would work for any either anterior posterior or vertical shear dysfunction, whatever is there. This methods would help in relieving it. So these are few references which I have from which I have taken this presentation from. And usually the quality of life would be poor if this becomes chronic. So it's very important to educate the pregnant women. Usually in Indian scenario, most of them would not be coming. Even if they come to us also, there is a lot of confusion between the low back pain and the pelvic girdle pains in therapists too. So it is important to get awareness about the pelvic girdle pains also, so that we can help across many women, pregnant women who are suffering with the pelvic girdle pains. Thank you.
Thank you so much, ma'am, for your wonderful presentation.
Thank you.
Dr. Megha, if you want to ask any question, or Dr. Bhavna or Kitty, you can also ask from Dr. Rawali. If any participant wants to ask any question from Dr. Rawali, they can ask in the chat box. I think no questions for Dr. Rawali. I think no questions for Dr. Rawali.
Okay, thank you.
Yeah. So thank you so much. Our next session, Gynae Colloquium, comes to an end. Thank you, Dr. Kitty and Dr. Rawali, for being our speaker, being with us. Last year also we had organized this summit, and this is the second International Web Physio Summit 2021, organized by Academy of Exercise Health and Therapy in collaboration with Assam Downtown University, Guwahati, as well as the European Register of Therapists, Europe, and Osteopro and Osteopathy Association of Italy. So I would like to thank our chairperson, Dr. Megha, and co-chairperson, Dr. Kapila Jain as well. And I would like to request Dr. Abhishek to give vote of thanks.
Thank you so much for wonderful presentation.
Dr. Abhishek, I think you're.
Now it is audible.
Yeah, thank you everyone. Thank you, Kitty. Thank you, Dr. Rawali.
जी मैंने रिकॉर्डिंग तो शुरू कर दिया, लाइव स्ट्रीमिंग कर दीजिए स्टार्ट।
आप करिए, मेरे से हो नहीं रहा।
अच्छा, होस्ट बना दीजिए, मैं कर दूंगा।
I want to listen.
हो गया जी।
Okay. So, good evening to all of you. Myself, Dr. Chirag Verma, Director and Chief Instructor at Academy of Exercise Health and Therapy. Now we have the Ortho Colloquium. In morning we had Neuro Colloquium, and in afternoon we had the Gynae Colloquium. There were 4 sessions in Neuro Colloquium, and 2 sessions were there in Gynae Colloquium. And now 4 sessions will be there in Ortho Colloquium. And for this Colloquium, we have our Dr. Manoj Malik sir as a chairperson of this Colloquium, and Dr. Devesh Seth as a co-chairperson of this Colloquium. So the first speaker in this Colloquium is Dr. Saurabh. So I would like to welcome all the participants in Second International Web Physio Summit 2021, organized by Academy of Exercise Health and Therapy in collaboration with Assam Downtown University, as well as European Register of Therapists, Europe, and Osteopro and Osteopathy Association of Italy. Welcome, Dr. Saurabh. Dr. Saurabh is.
Thank you so much, sir. Thanks.
So first lecture will be presented by Dr. Saurabh. I would like to give a brief description about Dr. Saurabh. Dr. Saurabh is MPT Ortho and having a 13-year of experience and HOD at Amarnath Charitable Hospital, as well as Dr. Saurabh is a certified kinesiotape practitioner from Singapore and instructor at Academy of Exercise Health and Therapy, as well as in charge for strategy planning in Academy of Exercise Health and Therapy.
Thank you so much, sir,
and
for
I
this
would
brief
like
introduction.
Yeah, I would like to request Dr. Manoj Malik sir and Dr. Devesh to allow Dr. Saurabh for the presentation. With your due permission.
Manoj sir, after you, please.
Unmute, please, sir.
Manoj sir, please unmute.
Sorry. So I welcome all the delegates, and I think Dr. Saurav has chosen a very good topic. It's very pertinent in present scenario where a lot of TKRs are happening. So I think it's very important for physiotherapists to learn the rehab role in TKR. Dr. Devesh, I think you want to say something. So
Thank you, sir.
Thank you so much, sir.
A very warm welcome to Dr. Saurabh.
Thank you so much, sir.
Sir, TKR is a topic on which there are many issues faced by physiotherapists. So I think this topic would be a great topic to be taken today by you. Thank you, sir.
Thank you so much, sir. Thanks a lot. With all your permissions, thank you so much. I think I can start the topic. I am sharing my screen. Thank you, sir. Thanks a lot. So today my topic is rehab role in TKR, a new perspective in TKR rehab. As we all know, TKR is day-to-day procedure now. It's not an exceptional thing which used to be 20 to 25 years ago. It's happening on day-to-day basis. And I'd like to add something new in it with day-to-day we are dealing with patients. So TKR or TKA in our medical terminology is totally arthroplasty, which is a common orthopedic surgery that involves replacing articular surfaces that are femoral condyles and tibial plateau, as we all can see in this diagram as well, of the knee joint with smooth metal and highly cross-linked polyethylene plastic. Right? It is just a replacement of osteoarthritic part which is due to arthritis damaged. Right? TKA aims to improve the quality of life of individuals with end-stage osteoarthritis by reducing pain and increasing movement. Thank you. And next, we have the rehab part main, because surgery we all see, and we as a physio should aim towards the rehab part. So there is pre-rehab also. There is
sorry to interrupt in between. I would like to ask Dr. Manoj and Dr. Devesh, is your Dr. Saurav's presentation visible to you?
yes, sir, it's visible to us. Visible to me. I don't know. It's visible to me.
Yes, it's visible. Yes, it's visible.
Okay. You can continue, Dr. Saurav.
Thank you. So as a physio, our role is to rehabilitate the patient of TKR. So what are the goals? When we see a patient of TKR, what are our primary goals? These are to control pain and swelling, to protect the healing tissue, begin to restore range of motion. That is a very important part, because range of motion issues we face as the patients doesn't come to us on the second or third day after being for home visit. They don't visit us, that we will face the issue of range of motion. Even if the exercises are not absolutely on the mark, then we can face the range of motion issues. So we should restore them from the beginning. Then knee flexion at least 90 degrees should be there. Knee extension less than or equal to 0 degrees. Because extension leg is there, patient won't be able to walk properly due to extension leg. So knee extension should be properly there, right? Established lower extremity muscle activation, because due to surgery the extremity will be less activated, so we have to activate all the muscles of the lower extremity so that patient can walk and the gait training could be done. Then we have to restore independent functional mobility, because patient feels dependent after surgery. So we should keep in mind that patient should feel independent for all the functional mobilities, right? Then precautions. What are the precautions that we should take? Weight bearing with crutches or walker unless otherwise ordered. When the patient gets surgery same day, nowadays we make the patient weight bearing with crutches or walker on the same day. right? Screen for sensory or motor deficits if there are any. Screen for deep vein thrombosis, systemic orthostatic hypotension, that is a very important thing, and systemic low hematocrit values. Next, what are the exercises that we start from the base? For range of motion, passive knee flexion extension, as patient won't be able to do it actively, so we should do it passively. Heel slide, that is possible actively, so he'll do heel slide. Active assisted knee flexion and extension in sitting. In sitting position, we should go for active assisted knee flexion and extension both. Ankle pumps, toe and ankle pumps are the basic exercises which usually we do in almost every surgery. Then we proceed on to the strength part. How we are going to develop the strength. Everybody knows, every physio knows quadriceps strengthening, quadriceps sets, glute sets, and then hamstring sets, right? SLR, very important exercise, emphasizing no leg of extension. Then hip abduction and adduction, because patients usually come to us after the surgery, they have some side sway due to the severe OA knee. So when the patients get surgery done, the knee correction is done, still the side muscles of the core are activated and then hip movements are sideways. So we need to train the hip adductors and abductors both in order to maintain the gait proper. Long arc quads. In sitting position, we do long arc quads. And then seated hip flexion is also as a good exercise. Functional mobility, which is very important part in order to achieve functional mobility, which things we do. First is bed mobility on bed, then transfer of training from bed to chair or bed to standing, gait training on level surfaces, because in initial stage, patient won't be able to stand on the level surface. So we should train him on the level surfaces. Then stair training. These days, the surgeries are so good that we can even achieve stair climbing on the next day. Activities of daily living with adaptive equipment, like canes, like walker. Then when in bed, what type of positioning should we do? Foremost is to promote the extension. We should use a towel roll under the ankle so that the knee should be straight and extended position. Proper extension should be there. No extension leg will be left. Second one is use a trochanter roll to maintain hip in the neutral rotation and promote knee extension. Trochanter roll is just applied just below the hip joint so that the maintenance of hip in neutral rotation should be done. Then there is never place anything under the operated knee because it will lead to extension lag. Perform 10 repetitions of all exercises 3 to 5 times daily. Use ice after exercising for 10 to 20 minutes in order to reduce the swelling or edema. Inpatient plan of care. On the day of surgery, out of the bed to chair, then PT evaluation is must. On the post-operative day 1, PT and OT both evaluate, then therapeutic exercises including ROM, strengthening, functional mobility, as I have just told, they should be continuous. Activities of daily living training as appropriate. Then post-operative day 2 to discharge, because most of the patients are discharged on the second day. Progression of therapeutic exercises and functional mobility is done along with continued ADL training. And phase 2, it is very important because we usually do home visits for this. So continue to improve range of motion with the goal of achieving at least 110 degrees of knee flexion. Begin to restore muscle strength throughout the operated leg with special focus on the quadriceps, because quadriceps are the main muscle group which will lead to extension or proper extension of the knee. So special emphasis is done on the quadricep. Then initiate proprioceptive training. Proprioception is an integral part of joint mobility. When the proprioception is good, the stability will be good. So initiate proprioceptive training by standing, sides, moving, etc. Initiate endurance training. Then normalize all functional mobility. Day-to-day functional mobility should be maintained. Wean all assistive devices, emphasizing normal gait. We should wean all assistive device within 6 weeks. No assistive device should be held by the patient within 6 weeks. What precautions should be taken? Weight bearing with crutches or walker, progress to cane, then weaning devices as appropriate. Monitor for proper wound healing, because if there is any sign of infection, the wound won't heal, and that will lead to a big problem. Monitor for increased swelling if there. Then quad sets, glute sets, hamstrings, the things which we are doing in the inpatient, they should also be continued. And which are the recommended exercises? Range of motion. For range of motion, continue with all phase 1 range of motion exercises. Heel slide with towel. Prone knee flexion can be started. Heel towel under the ankle and prone knee hang to promote knee extension, so that there shouldn't be any extension lag. That is very important. I am emphasizing again and again on the extension lag, because once it is left, it is very tough to correct. Initiate stationary biking, starting with back and starting with back and forth motion, progressing to full revolutions as able. Then joint mobilizations and stretching. Initiate patellofemoral and tibiofemoral joint mobilization as indicated. Initiate hamstring, gastrocsoleus, quadriceps. That is all lower limb strengthening. Then quads, glutes, and hams also. This is the image which I want to show. That is a special thing. It is kinesiotaping in TKR. We do it usually to reduce the edema and also to increase the blood supply. In case of TKR, the patient feels very good after applying kinesiotape for 3 days. This is first images, anterior view, lateral left knee, post-operative day 5, and it is you can see that kinesiotape is applied on the back side. Figure 2 you can see on the lateral view. In next image, you can see within 3 days the ecchymosis is almost reduced to more than half with help of this kinesiotaping, right? In figure 3 you can see. In figure 4 you can see the back side of the knee, posterior side, in which we have applied the kinesiotaping in order to reduce the increase the lymphatic drainage and reduce the edema. We can use neuromuscular electrical stimulation to quads if poor quadriceps recruitment is present. SLR without lag.
Dr. Saurabh,
Yes, sir.
Your slides are not changing.
Yes, slides have changed already, sir.
What I can see is the phase 2 hospital discharge 6 weeks.
Yeah. I'm also seeing that. That's what I was asking of. Phase 2 hospital discharge 6 weeks. That slide we are showing to. That slide is showing to us.
Again, I'll.
So
What you have to do is, sir, just stop sharing your screen and then reshare again.
Then again reshare it. Yes, that should work.
Okay. Just a second. Just wait for a second, sir. I think we were on the second phase, which you could see. This slide was visible last. Is it, sir?
On my screen, I can just
May I know,
see
sir?
that you started screen sharing, but no slide is visible. Is it same with everybody? Like Manoj sir, Dr. Chirag?
Showing Dr. Saurabh has started sharing screen.
Yes, that's what I can see.
Yes, same with me.
मेरी इसमें दिखा रहा है Dr. Saurabh has started screen sharing.
Same sir, same.
Okay, there is some issue. Let me check again. Stop share.
Participants here.
There is some issue, but I'll still try to manage it.
what you can do is, Dr. Saurabh, send your slide share to me. I'll open in my computer and you can read out that if possible.
Just a second, I'm trying my best to it.
What you can do is,
Just a
Dr.
second.
Saurabh, just leave this meeting and rejoin again.
Okay, let me try.
Because in streaming also, it is not showing. Participants are saying the same thing. I think a network issue is there with Dr. Saurabh.
The weather is playing the spoil sport due with the network.
Yeah, that might be an issue. I think the network error is with Dr. Saurabh. So with your due permission, Dr. Manoj and Dr. Devesh, can I introduce the next speaker? The rest time we will share with Dr. Saurabh. As
Yeah,
of
we can do
Sure,
so.
please. Sure, please.
Sure.
Dr. Saurabh, am I audible to you? How's the weather, Dr. Manoj, over there?
Yeah, I'm there only.
No, how's the weather?
Weather is like it's a bit rainy. I think in Hisar and Sirsa that's maybe an issue with the.
Yeah, same in Delhi. Same in Delhi.
That may be the issue.
Same in Meerut also. Heavy rain in the evening.
So I think Dr. Shishir is also there. We can start with Dr. Shishir. We can welcome Dr. Shishir and start that session. Yes.
Hello, good evening, everybody. I'm
Good
ready to
evening,
start.
Dr. Shishir.
I'm ready to start if you want.
Sir, I think Dr. Saurabh is here again. With your due permission, we can give him his remaining minutes.
Yeah, sure. Why not?
Yeah, Dr. Saurabh, you can try. If not possible, then we'll all request Dr. Shishir to start. Dr. Saurabh, unmute yourself.
There's a network issue with Dr. Saurabh.
Might be possible. Dr. Manoj, Dr. Devesh, I have talked to Dr. Saurabh. He said that network error is there. So I would like to welcome Dr. Shishir. Dr. Shishir is a Lieutenant Colonel, retired from Army, and he is a senior most spine surgeon and head at JP Hospital, Noida, as well as Metro Hospital, Noida and Narayana. Dr. Shishir has done various spine surgeries of scoliosis, shoulder arthroplasty, knee TKR. That's what Dr. Sora was telling for rehab. So Dr. Shishir was in rehab part as well in the army, and I am glad that I am working under Dr. Shishir, to be associated with Dr. Shishir. I'm so much blessed, even I can say, because day by day I'm getting the knowledge from Dr. Shishir, and he is senior most. He has served in 30 years in army. He was passed out from AFMC Medical College. So I would like to request Dr. Manoj and Dr. Devesh to welcome Dr. Shishir in the second International Web Physio Summit.
I welcome Dr. Shishir, and I think it will be very interesting to hear about the past, present, and future of spine surgery. And I think we can correlate with it, and we can have new dimensions to future of pre-operative and post-operative physiotherapy also. So I, on the behalf of International Web Physio Summit 2021, I welcome Dr. Shishir. Thank you, sir, for joining.
Thank you, Dr. Manoj. It's been indeed a great pleasure for me to be part of this gathering. And I have come in association with Dr. Chirag, a very brilliant, young, dynamic person. And I'm happy that I'm associated with him. And he invited me for this talk. So I have kept this, I'm keeping this talk as a basic overview of what was being done in spine, what was being done in spine, what is being done in spine, and what are the future possibilities in spine. Since all of you are trained experts in physiotherapy, I'm not touching on those aspects of spine because you people are already trained. So I'm just giving you an overview of what all is possible, right? So I think I'll share the screen now. Can you see the PowerPoint? Is possible?
Yeah, sir, it is showing. Thank you.
Yeah, it's visible, sir.
It's showing. Thank you, na. So okay, we can go for the start then. Okay, so as Chirag already said that I have spent about 24 years in the army. My primary training was in general surgery, after which I did fellowship in trauma surgery, followed by orthopedics, and then multiple fellowships in spine surgery. I got experience for more than 25 years in spine surgery. I'm also a joint replacement surgeon. I do a lot of joint replacement. And I was in charge of the spinal cord injury center of the armed forces in Pune for about 4 years. And because of which I have considerable experience in rehab, not only of spine patients, but also other patients. That's a state-of-the-art center. And I suggest that if any of you ever go to Pune, especially if people from your field, you must go and visit this center called Spinal Cord Injury Center. This is in a place called Khadki in Pune. So now Hippocrates in the 5th century BC is the one who describes spinal fractures and deformities which have occurred because of these fractures. And in those days, Hippocrates had devised a ladder where they would hang a guy upside down and then apply traction to straighten the spine. Also, there a person would be strapped and a person had to stand on his back to correct the deformities. Now, in those days, as you know, the deformities were commonly either tuberculous or traumatic, and the results, as you expect, were not very great. So the landmark discovery for spinal surgery was first of all the discovery of anesthesia, where the patient could be operated safely, and then more importantly the advent of X-rays, where the spine could actually be visualized in real time by an X-ray. So with these two, our knowledge of spine about the spinal elements increased by manifold, and a lot of vistas were open for us to intervene because of the anesthesia. Joel Goldwith was the first guy to associate that that disc disease is radicular pain, that a prolapsed disc once could impinge on a nerve root and cause radicular pain, and so which made way for the first discectomy, which was carried out by Mixter and Barr, who did a laminectomy and discectomy to treat radicular pain due to disc herniation. And they were the ones who described and defined the surgery for prolapsed intervertebral disc. Unlike now that we do surgery by retracting the dural sac, they went through the dural sac and removed the disc. But one of the fathers of orthopedics, and Smith-Peterson, who has devised many other orthopedic surgeries apart from this deformity correction surgery, also called Smith-Peterson osteotomy. He worked on a lot of patients of spinal deformities in those days, most commonly because of tuberculosis in the West, and devised what is called the Smith-Peterson osteotomy, which we still use. The revolution was brought in the management of scoliosis by a gentleman called Harrington in the 1940s and 50s, where he devised this device called the Harrington rod. This Harrington rod had hooks which would go in the sublaminar and the supralaminar region, and one could distract this Harrington rod to slowly correct this deformity. This Harrington rod, when I started my training, Harrington rod was one of the only methods available for correction of scoliotic deformities when I did my undergraduate training and when I was going into my post-graduation. So, but the truly modern era deformity correction was brought about by this gentleman called Pierre Roy Camille. And Pierre Roy Camille was the one who used the pedicle screw-based system for correction of deformities. Now, if you see, the problem with Harrington's rod was that it had only two anchor points in the spine. And at those anchor points, they would often give way as a child grew, or as a child, or as the bone became a little more brittle. So Roy Camille brought about the concept of pedicle screws, which we are using now. With the help of pedicle screws, we were able to take control of the whole spine, the anterior, middle, and the posterior column, as you know that the spine has got. And we were able to take control of the spine and then carry on very complex and complex deformities correction because these pedicle screws were very stout. They had very good purchase into the spine. So Roy Camille heralded the modern era of spine surgery, and it is from the 90s that we started using these pedicle screws, progressively refining the kind of screws that are available in the market. And but the basis remains the same, that the pedicle screw go into the pedicle and go through and control the force nucleus of this vertebral body, thereby controlling all three columns of the spine. And so we were able to herald in the new era of spine surgery. So now, what is the commonest thing that we encounter in our practice at the moment? And that is degenerative spine disease. All of you are aware that degenerative spine disease is basically an age-related process. It starts affecting people all beyond 30 years of age. And it is as certain as death and taxes. However, with this degenerative spine disease, not all become symptomatic. And there is always a great dichotomy between MRI and the clinical findings that the person sees. A person may have a very, very bad MRI, but may be totally symptomatic. And on the other hand, he may be very symptomatic, but the MRI may not be showing those severe kind of stenosis. So the degenerative spine disease, which is the commonest condition, has to be related clinically and radiologically so as to define the further method of management. Another commonly encountered problem presently is the prolapsed intervertebral disc, which all of you are well aware of. And the initial process, it starts from a bulge with minor back pain to a prolapse and extrusion, which may give rise to excruciating back pain with radicular pain and with or without neurological deficit. and a very large disc inside a canal may also give rise to Colloquium syndrome. So a disc disease causes back pain, may cause radicular pain, may also cause claudication because when it becomes chronic, it causes a lot of occlusion of the foramen and may cause claudication. And it may also cause the most dreaded complication of Colloquium syndrome. So in degenerative spine disease, as you can see here, the spinal cord is bound in a rigid bony canal most often by the lamina posteriorly with the ligamentum flavum, the facet joint capsules laterally, and the disc anteriorly. So now any of these things growing may start decreasing the diameter of the spinal canal, thereby causing spinal stenosis. The commonest is the ligamentum flavum and the facet joint capsule, and this is associated with some additional problems from the disc. This MRI shows very clearly how the spinal canal stenosis progresses. This is grade 1, where the spinal canal is large, very little flavum hypertrophy is there. This is grade 2, where more flavum hypertrophy is there, and the canal progressively started narrowing to grade 3. And you can see that the grade 4, the canal has got so narrowed that the nerve roots have got bunched inside. And there's a picture seen where the nerve roots look like a clump on an MRI. So how would a patient of canal stenosis present to us? Because unless we are able to identify what the patient has, we will not be able to offer him what are the modalities of treatment. So the patient of canal stenosis initially present with leg pain. He will say, I have got bursting pain in my leg, or mere pair phatte hain. And pain would be normally is in two legs, in both the legs. But if it is early or unilateral kind of stenosis, or beginning of stenosis, he may start having pain on one of the legs. And this pain starts on walking, and then if he sits down or leans forward more often, then it becomes a neurogenic claudication. Because of instability, he would be having back pain and severe back pain. And as the disease progresses, he would probably be having numbness of both legs and eventually develop neurological deficit and bowel bladder incompetence. So treatment of spinal canal stenosis and collapsed disc is obviously initially conservative. Rest is the basic hallmark of all treatments of the back. Initial treatment of the thing is analgesics with rest, muscle relaxants, and we advise spinal flexion exercises if there is foraminal stenosis. May need to give some amount of lumbar support if there is instability or spondylolisthesis. And IFT, local heat, short wave diathermy, I leave it to you people. You people are best judge of how and to go about it. But I generally advise indifferential therapy if there is radicular or neck pain, and local heat like short wave diathermy, etc. for local pain. So more importantly is that you would be, as a physiotherapist, you would be getting lots of patients in your physiotherapy with the spinal problems, especially radicular pain because of prolapsed disc, and also because of spinal canal stenosis. And at times, our younger colleagues, our younger physiotherapy colleagues, are not able to decide or decipher which patients actually they should continue to treat, or which patient they should be sending to us for some kind of intervention. So patients who present to a physiotherapy center or a physiotherapist should who has acute onset of radicular pain should be referred to a spine surgeon for basic primary evaluation, whether the cause of the pain is a spine and whether there is some amount of deficit, and whether it is actually occurring from the spine, or the radicular pain could be things like piriformis syndrome, or some lumbar plexopathy or stuff like that. Long-standing radicular pain, which is being treated in physiotherapy centers for at least for about 2 months or 3 months, and if they do not get relief, should be sent to spine surgeons for further intervention. Any patient who is having radicular pain with the neurological deficit should not be treated in a physiotherapy suite and should always be sent to a spine surgeon, because these are the patients who require decompression, and otherwise the neurological deficit becomes irreversible. Bladder and bowel involvement is obviously an emergency kind of situation in spine problems, and any patient who is having back pain, who's having leg pain, and has developed bladder or bowel incontinence should straight away be referred to the thing to a spine surgeon. Patients who are having neurogenic claudications which do not improve despite all the exercises, the physiotherapy measures, and which have now started interfering with the patient's way of life, should be referred to a spinal surgeon. Needless to say, any backache with deformity cannot be corrected on its own by physiotherapy, and especially if it is an organic deformity, or basically a structural deformity. If it is not a functional scoliosis or something because of functional back spasm. So, and any spinal deformity like scoliosis or kyphosis or kyphoscoliosis should be referred to a spine surgeon. So these are the basic things where patients should be referred to a spine surgeon, and the rest can be managed very effectively in a physiotherapy suite. So what are the treatment modalities available with us spine surgeons at the moment? The very simple and straightforward one, very simple thing is to basically give epidural or nerve root steroid. We actually give a triple steroid dose. That means one in the nerve root, one in the epidural region, and one at the facet joint. And these kind of patients, 70% of these patients tend to benefit by either epidural or these shots. 30% patients do not. We have seen in practice that about 30% patients do not improve and may need to be treated by some other modality. And then selective nerve root blocks not only help in treatment but also help in diagnosis. Sometimes patient may be having radicular pain, but we are not very sure whether the radicular pain is from a certain root. For example, patient may have discs at two levels, L4 and L5, L4 or L5 and S1, and we are not sure which is the level from which the pain is arising. So giving selective nerve root blocks at these levels not only help us to relieve the pain, also help us to identify the index level for pain. And our commonest thing that we give is methylprednisolone, but we can also give hyaluronidase and carry out chemical neurolysis by injecting larger volumes of saline. As I said, we give all three. Nowadays, we started giving all these three together. A facet joint injection is very effective in people or elderly people who have got facet joint hypertrophy and facet joint pain. But we need to dissect. We need to decide which are the patients who have facet joint pain. And even this injection actually is diagnostic for facet joint pain. If you're able to effectively give it in a joint, then it gives us a very good idea about the facet joint pain. Once the patient does not improve by surgical interventions, by conservative measures like physiotherapy, like the injections that we give, we need to go in for some kind of surgical interventions if when indicated. So there are certain market-driven modalities which are there, but which I have just enumerating, which are not to be taken seriously, and that is basically intradiscal electrothermal therapy, which is basically primarily for discogenic pain. But for us to find out exactly whether the pain is only discogenic or is because of disc and facet joint or because of muscle or because of ligament is near now impossible, and you will probably have to do a provocative discography. So the limitation of this modality is very, very limited indications for this. And if only one is very sure after provocative discography that the pain is because of the disc space, then only this is indicated. Often in spine, the pain is multifactorial in origin because the process of degeneration affects not only the disc but causes instability of the facet joint, hypertrophy of the capsule, and therefore just giving this injection does not suffice. Similarly, again, radiofrequency ablation of the disc by a wand again is a very industry-driven driven process. And the indications of this are very few, as I mentioned. Those the gold standard for disc disease, that is sciatica and disc disease, is basically a microdiscectomy, where a very small incision, about 2.5 centimeter incision, is given, and with the help of special retractors and a microscope, the disc which is compressing the offending disc which is compressing the nerve root is removed. And you can see here that we go from posteriorly, very little muscle. Now we have got tubes where we are using muscle splitting approach rather than the muscle, erasing the muscle from the midline raphe. And so most of my patients that I operate are sent home in the evening. And we admit the patient of sciatica in the morning, and most of them go back. You are welcome to refer to my website and my YouTube and Facebook channel. There are numerous interviews of such patients that are there. You can see here that that offending disc this is the approach. You come from behind. There's a midline, but now we have started coming from here. We retract this nerve root and we pick up the disc and clear off this nerve root. Then comes the surgery, which is a little more than this, when there is instability, and we would. Now, in the previous days, now you can see here, this is a classical case of instability with grade 1 spondylolisthesis. And you can see these are the foramens at the 4, 5, and 3, 4 level. These are foramen at the L5S1 level, and the patient presents claudication, back pain, neurogenic claudication, at times some amount of neurological deficit also. And you can see in the MRI that the foramen is totally, this is a normal foramen, these two, and you can see that this is nerve root which is being compressed in the foramina here. And this is the amount of listhesis. So this patient will require decompression and stabilization of the spine and with fusion, because otherwise the implant would give way if we don't fuse it. Sorry. So traditionally, such opening of the spine from posteriorly, fixing up screws and decompression. But now we are able to achieve it by a conventional open, and this entailed serious muscle splitting, muscle cutting, causing devitalization of the muscle and pain and delayed mobilization of the patient, prolonged hospital stay, and loss of man hours. And so now we have developed techniques where we are able to carry on this surgery in a very minimally invasive way. So here you can see that we insert retractors, tubular retractors, at the level, that index level where we have to operate, and these are they're inserted through a muscle splitting approach through the paramedian area, through the rectus spinous, so that none of the muscles are devitalized. And through this, we remove the facet joint, that is offending facet joint, enter the disc space and pass in and put in cage and bone graft. And you can see this is a cage, and we are putting in a bone graft through this tubular retractor. After we put that, we stabilize the spine by putting minimally invasive pedicle screws by small stab incisions like this. And subsequently, we achieve a transforamen lumbar interbody fusion. You can see this is a cage that we have inserted. These are pedicle screws that we have inserted, and we have decompressed the whole spine through that tubular retractor. And you can see that these are the incisions that are there. Patient is up and about the same evening. Is we start the next day as compared to a scar which would have been so long. Nowadays with the lifespan increasing, more and more patients are living to be 70s and 80 years old, and with that comes the problem of osteoporosis. And you can see here is a classical osteoporotic compression fracture here. And this patient, earlier days, the treatment was giving a lumbar corset and making them lie down 4 to 6 weeks. And even after that, they was quite symptomatic, and using additional bisphosphonates and vitamin Ds and all, and they would take a long time. These patients would require a long time to recover. Now we have got techniques like balloon kyphoplasty, where through a pedicle or through an extrapedicular approach, we go into the disc space, we inflate a balloon, and we insert cement. As you can see here, this is a osteoporotic compression fracture, where we have gone in, elevated this by a balloon, the upper end place, and inserted cement. And this procedure is done under local Patient is so symptomatic when he comes to the hospital in a stretcher and walks out of the operation theater, and he goes into the operation theater on a stretcher and comes out walking of the operation theater. Such dramatic is the relief for the patient. Moreover, most of these patients are very old, about 80, 85 years old, or 80, so they cannot undergo any of the surgery. So this becomes, under local anesthesia, becomes an effective procedure for relieving back pain. Apart from this, many other surgeries are being performed, and one of them is scoliosis. As you see, that this girl is in case of adolescent idiopathic scoliosis. You can see she's got a lumbar curve and got a hump. And here we have done scoliosis correction by posteriorly applied pedicle screws. As I told you, pedicle screws help us in strong correction of the spine. You can see this is a scar and the hump is totally gone. Tuberculosis is very common in a country, and many of us get tuberculosis. You can see here the patient of tuberculosis with paraplegia, so we had to go and put in a cage and decompress the spine and put this. I now, being the senior guy, I get a lot of revision and bad deformity surgeries. You can see there's a boy who's got a congenital kyphotic deformity because of him vertebra, and somebody has gone in from anteriorly and just tried to place in a cage between vertebra, which of course is biomechanically very poor, and so spine has collapsed. So we have gone in again, and we have, from the behind, we have put in anchors in the form of pedicle screw, removed that bone, put in bone grafts, and then corrected the deformity. And you can see the child has grown up. This, I think, after 7 to 8 years, he's turned out to be a strapping lad now without any kind of deformity. Again, I get a lot of revision, and we are able to do a lot of good corrections here again by some young surgeon who have done tuberculosis deformity. The screws and rods have given way, bad deformity, patient in severe agony, rods jutting out into the back. So we went in and did what is called a pedicle subtraction osteotomy. Here you can see 2 vertebrae have become 1, and we have corrected the whole deformity, spinal deformity. His back is straight. He had neurological deficit, which improved, and he went out of the hospital walking and is fully recovered. There again an interesting case again where this was a young girl, and she fell down from the 3rd floor and injured her back, and she was taken to some hospital where, unfortunately, again, people who were not so well versed in spine surgery carried out the surgery, and they did an anterior fixation of the spine. Unfortunately, the spine gave way because it was not stable. Also, unfortunately, she developed gangrene of the right leg because of some amount of neglect, and the right leg had to be amputated. So we went in again, very difficult surgery again. We went in again and utilized, and from behind, and utilized the same cage to correct the deformity, and this improved her neurological function also. And I gave her an artificial leg, and the girl was able to walk, and we gave her a foot orthosis, AFO, ankle foot orthosis for the foot drop here. This girl was able to walk. I operated her about 8 months post surgery, and she was able to walk 8 months after surgery. This is a very interesting case, and I had done this patient free of cost. This patient was called Chitra Thapa. By showing this case, I'm trying to show you the scope of what spine surgery at present. So this patient, as you can see, is a case of juvenile rheumatoid arthritis. He's actually 28 years old and is wheelchair bound from 13 years of age. That means in the past 15 years, wheelchair bound. His knees are ankylosed in 90 degrees, his hips are ankylosed in 90 degrees, and his spine is totally kyphotic. You can see this is his posture. He's got no movement in the spine or in the neck, none in the hip and none in the knee. And so you can see again another view. So very, very difficult to give him anesthesia. You can see. So you can see these are X-rays. Both his hips have got bony ankylosis. Both his knees have got bony ankylosis at 90 degrees. And his spine has got severe kyphotic deformity, with a spine being breaking by about 33 centimeters from the spinovertebral line, the sacral line. From C7 sacral line, there is a normal angle should be not more than 5 centimeters. Here it is 33 centimeters. So there is very significant deformities. So I went in and did one. I did in the first setting I did one of the hips and the knee. In the second setting I did the other hip and the other knee, and then evaluated him and found that despite all this he was severely kyphotic. So I had to go in and do a pedicle subtraction osteotomy to straighten the whole, to bring up the whole spine and straighten the spine. As you can see there, this is both the hips have been replaced, both the knees have been replaced, and I've carried out a pedicle subtraction osteotomy, and you can see now the C7 is right over the sacrum, and so there is a very, very significant correction of the spinal deformity. And you can see a person is totally straight sitting up. I had to leave residual 15 to 20, 25 degrees deformity in the knee, because otherwise stretching it further would have jeopardized the nerve. And so we gave him stretching exercises by which it has improved further, and now he's got only about 5 to 10 degrees of FFD. But the remarkable thing was that after 15 years, he walked. For 15 years, he was bedridden, and this is him walking after 15 years. You can see he's able to lie down straight on the bed. It just the knees are slightly bent as compared to his previous position. The previous position like this now, he's able to sitting and walking normally. You see, this was his posture earlier, and this is his posture now. And now he's gone back and he started studying in Nepal, and he's continued his education, and he's walking with the help of walker, and he's passed his class 10th now. So this is what we are able to accomplish now in spine surgery. Our dedicated spine surgeons are able to do the whole gamut of these surgeries and give relief to the patients. Now, what holds in the future? Now, the biggest problem with the spine surgery in spine is present is that we have to put in pedicle screws, which are basically going from posterior to anterior. And despite C-arm or O-arm, it becomes a hazardous procedure because the nerve root is lying inferiorly and the spinal cord is lying medially, and there are largest chances of injuring these things. Even in the best of hands, the rate of misplacement of these screws is about 5%. The most experienced guys like me who've done for 30 years, but if you evaluate, I would probably still be misplacing the screws in about 5%. So robotic surgery has evolved because of that, to place these screws and do this correct difficult surgery, especially when the spine is crooked, when the pedicles are very small. Then what we do is that first of all, we create a pre-operative blueprint of the spine, and that pre-operative blueprint is placed on a monitor, and with the help of markers or a robo, the screws are being placed very, very safely at every time, seeing them inside the monitor. So now this gives us a very, very high degree of accuracy in placing these anchors, our anchors for correction of these deformities. And then another aspect of spine surgery where we are still at loss is spinal cord injury. All of you know what a devastating complication spinal cord injury is, especially in a young person who's in the prime of his life, prime of his youth, and he develops paraplegia or quadriplegia. Despite all our efforts, at the moment we have no treatment for such patients. The future lies only in regeneration of spinal cord by stem cell therapy. Lot of research is going on stem cell therapy, and if not my lifetime, in younger people like your lifetime, we would probably be getting certain results of stem cell therapy. I must take this opportunity to warn all of you people that there are very fly-by-night operators going around in the market who are claiming to benefit spinal cord injury patients by stem cell therapy. Stem cell therapy is in infancy. Stem cell therapy has not been developed to an extent where spinal cord regeneration can take place. Their stem cell therapy people, they are fooling them for patients of AV and hip also, and many other disease stem cell therapies, but it is not a proven modality at all. Results are very poor at the moment, and results are very poor at the moment, and so with this I would end, and thank you for showing a patient listening.
Thank you so much, sir.
Sorry, I hope I have not exceeded the time. No, I have not on time.
So you are not
Yeah.
on time.
I was told half an hour, so I have deliberately taken
Yeah,
half.
you have taken 40 minutes.
40 minutes. I took the time of the previous speaker.
Yes, sir. Actually, you have taken the time of Dr. Saurav as well.
I'm sorry.
No issues for that, sir.
Any questions?
Yes, sir. Actually, this Zoom session is being streamed over that transcript session. So it will take around 15 seconds to be properly streamed. So let us wait for the participants to get the questions.
Okay.
But overall, it was a wonderful session, sir. Thanks for throwing light on the surgery on spine, sir.
Sorry?
Thanks for throwing light on the surgery of spine, sir.
I just want to show you what all can be, what all is done and what all cannot be done, which is also equally important.
Yes, sir. Dr. Chirag, do we have any questions from the live session?
I'm waiting for all those questions. Just it will take 15, 20 seconds.
Meanwhile, we are waiting for like questions. I can say, sir, it was a very great session, and I can add on like you had shown some case studies of kyphosis, and so if functional deformity is there, physiotherapy, certain spinal manipulations, posture correction, they are also very effective, sir. So we can collaborate with all these things.
Certainly.
So they can add on the benefits of your surgery and
Physiotherapy is best, most effective when there's a neuromuscular imbalance or there are postural deformities.
Yes,
But, so those are the, plus physiotherapy is also beneficial in patients whom we are managing, especially children, whom we are waiting to grow up so that we correct them. So to prevent progression of the curve, and the physiotherapy becomes very important at that time.
And now it has like initially when I started with there was like very conservative defined physiotherapy. Now spinal manipulations, posture correction, a lot of things are added, and now physiotherapists are practicing in India. If it is functional, then it can like very well help your surgical part. So
certainly. In fact, spinal manipulation in the form of halopelvic traction also we are using in very complex deformities where we want to do some deformity correction or more than 100-degree curves and 20-degree curves. So those kind of stuff also we are doing. Physiotherapy is an integral part. Pre and post physiotherapy is an integral part of all spinal management. One cannot exclude physiotherapy out from management. Physiotherapy is not the end. Spinal surgery is not the end. All of them together form an integral part of the management of the spine.
Yes, yes, sir. Very true, sir. Very true.
Okay.
I think, sir, no question from the participant.
Okay.
So we would like to thank Dr. Shishir for guiding us, for enlightening his great knowledge with us for spine surgeries, because in India, people are more worried about spine surgeries that kuch ho jayega, theek nahi honge. But I sees over day by day in OPD with Dr. Shishir that he does many of the successful surgeries he has ever done previously as well, and patient have a confidence that Dr. Shishir will treat me better more than anyone else.
Thank you, Chirag. Thank you for the nice words. Okay, thank you very much. Pleasure. Bye-bye.
Pleasure to have you, sir.
Thank
Pleasure
you.
to have you.
Bye-bye.
Thank you so much. Bye-bye, sir.
So our next speaker is Gonzalo Velasquez. He's a PT. Working in Chile, South America. And he's a movement specialist. And he's our chief instructor for functional manipulation for movement dysfunction as well. He's a clinical director at Movement Solutions, Chile, South America. And he's an exo specialist as well.
Hey, Chirag, shall I start or shall I wait a little bit more? You tell me.
Yeah, you can start.
Okay. So first of all, I will share my screen. I just want to thank you, Chirag, especially to you, like always, for trusting in my work, and all of your team that is backing you up for doing this great job, for sharing the knowledge around the globe. So I will just share my screen. Please let me know if you guys see the screen. Is that okay? Can you let
Yes,
me know?
Dr. Gonzalo, the screen is visible.
It's visible? Okay. So today's notes are about and something that's very important. Please remember that my mother language is Spanish and my second language is English. So if sometimes I get a little stuck with English, that's the main reason. So I would like to ask you for forgiveness for that. So we will speak today about functional manipulation for movement dysfunctions, and essentially how manipulations can serve to change movement behaviors and pain behaviors. That's what's this about. And in order to do that, Chirag already told you a little bit about me, a little bit about my background. I'm a physical therapist. I have a degree in a master's in osteopathic techniques. And most of my background is also related to functional movement systems, FMS and SFMA, and exos as well. I'm an exos fitness specialist. So all of what I'm talking to you about comes from like a mix from all of these great organizations and great knowledge. And that's how functional manipulations for movement dysfunctions came alive. So what we traditionally have seen or do, we would have this bulge or this herniation, and related to this, we would take a lot of decision making has been totally biased by how or by the things that we have seen in images, in MRIs, in X-rays. And related to what we have seen in the images, we have chosen to do stuff like this. That's what most of us have been educated about. If I see this in an image, in an MRI, for example, of course, without a lot of clinical reasoning behind it, but if we see something, we take an action related to it, we get into this lumbar positioning, and we take like a lumbar manipulation in order to help the patient or the person to get out of pain somehow and recover somehow their movement. That's what we have traditionally do. And what we've been taught, I say we because I have been taught the same thing. But we have to check a little bit about the evidence and what the evidence have to say about this. And probably, I'm not saying that this is not helpful, because that would be lying, because we know this helps, because if not millions of people would get access to this and get help from this. But there is also another way of seeing it, and that's why I'm here today. So does any evidence support these claims that I have an image in my lumbar spine, and related to the lumbar spine image, I take an action in the lumbar spine? So there is this famous study from Brinhicki on 2014, where he took 3,000 people without lumbar pain. And what he found is that 50% of 30 years old people had 50% have these degenerations. So please recheck this. So 30 years old, no lumbar pain. Half of the people, 1 out of 2 persons, had these degenerations and no pain. And if we check these bulges, these protrusions, the numbers doesn't change that much. So these bulges in 40% of population, protrusions 30% of population. So 1/3 of population had these bulges or protrusions and free of pain. So this is a little bit challenging because we've been taught that if you have a lumbar herniation, you would have to take this action in order to help people to get them out of pain. But the whole thing is that there is a lot of people with these pathologies and no pain. So one of the things that we now know is, as a translation for this information, is that structural damage does not equals pain. It can help to, we can have bigger chances to develop pain, but does not mean that we are going to have pain. So that is pretty interesting in our decision making, our clinical decision making and our reasoning, in order to choose how to use or not manipulations in order to change movement and pain. So what are the things we have around? We have these studies of Joel Bialowski. In 2009, he started showing us this and proposing some mechanisms of how manipulation work, having this mechanical aspects of manipulation, neurophysiological aspects of manipulation, and placebo aspects of manipulation. So the mechanical aspects are related to the input, is to the actual or placing of the hands into one person, and what mechanical changes happen out of our hands. And there are not that many information till now that when we place our hands in people, because of the mechanical aspects of our hands on them, there are many changes. Though there are a lot of information coming in the last 20 years about the neurophysiological aspects of manipulation, and also too of the placebo aspect over the processing of the information when we place hands on some people. So what's the translation of this information? There are not that many mechanical reasons why we use manipulations and change movement and pain, but many other reasons why this works. And we know this works. I'm not here to let you know that this doesn't work. Now there's been like a witch hunting. Sometimes with manual therapy, like manual therapy doesn't work. Totally works. The whole thing is maybe what's the rationale behind it? What else is around? What else is around about manual therapy, about manipulations, about movement? This is, of course, a huge summary, of course, but the idea is to challenge some concepts that have been around and we have believed for many, many years. So we also have the model, the joint by joint approach. This is a regional interdependence model, where we have this model where we have segments of the body that need to have stability and some other joints that need to be mobile. So in this case, the foot needs to be stable, the ankle needs to be mobile, the knee needs to give us stability. The hips need to be mobile. Lumbar spine needs to be stable, and goes on and on, one by one. Stability, mobility, stability, mobility. And we can go even deeper into all of the small joints that are all around into this big parts that we have been seeing, now. But also in this regional interdependence model that it's supported by evidence, we also have something that we sometimes don't see as physios, because we've been taught about joints and muscles and tendons, but something that I love about osteopathy is how we interconnect things in all the other systems. When we see the vascular system, everything is connected, even though it's taught, people teach us that this has a name and this other part in the body has another name, but it's the same person, the same body. What else can we talk about? The peripheral, the nervous system in general, actually, like how median nerve can be connected with a sciatic nerve. So, for example, sometimes then we can't not touch the toes and have a cervical vercalgia can be helped by touching their toes or by a lumbar manipulation, and the pain is in the breast. It is connected, even though there is not much evidence supporting this right away because it's not been studied, but I'm pretty sure that people that have been working with manipulations and regional interdependence models have seen this many times. And also the fascial system. The fascial system, the skin itself, if we touch one point of the system, will generate tension in some other points of the system and vice versa. Okay? So if we have this, we need to realize sometimes that even though the evidence doesn't support right away that the tissue is the issue, sometimes the tissue can be the issue. But if we see, there are many tissues that can be the issue. Yeah, we have joints, we have skin, we have muscle tendons, we have vascular, we have visceral problems that can affect how people move and if they're in pain or not. And we also have ligaments. But if you see this graphic, there is a line around all of these tissues. There is a common line. And if we see that common line, it is when magic sometimes happens. We now know that movement is essentially like a black box. We just can see the output, but we don't really know exactly what's happening inside in the processing between the input and the output. But so changing the tissues is quite difficult to know what tissue actually we're changing. But what we know is that movement is what all of them share. When I talk about this line that all they share, that's movement. When you do a movement screening, all of the tissues are being tested. Even though we don't know exactly what tissue is being tested, when I do this with my breast, I'm challenging all of the bioflow or all the tissues that are in the front of my forearm, all of the tissue, all the neural tissue, all of the vascular tissue, and all of them can be changed through movement. So movement is what all of the tissues share. So this is like an introduction to understand or to show you why I'm proposing movement-based manipulations. Why? Why, if there is a history of other schools of thought that have been very successful using manipulations, why movement-based manipulations? Essentially, most of it comes from what I showed you earlier. Imagenology, tissues don't show you exactly how to deal with things. neurophysiological effects are the main part of why changes happen with manipulations. And maybe also probably manipulations doesn't have to be that complicated. That's something that I really believe. And if we get this to function, we get this to the people that we care. People do not care about structures. They just want to reach their goals. They do not care if they have a lumbar disc herniation, and that's a classic way of thinking, like, oh, I come to visit you because I have a lumbar disc herniation. But if we dig deeper, that's not true. People don't come to see us for a disc herniation. People come to see us because they are in pain, that they cannot do something that they love. And if we come back to this, it's quite simple, because if people would come to clinical professionals because of lumbar herniations, all of these people in here should be in a clinical setting, and they're not. This was just a finding in a MRI because they were doing a study. So people do not care about structures, they just want to reach their goals. So that's something that we have clear now. So what is FMMD? FMMD is a new paradigm of manual therapy based on human beings, not pieces of meat, not pieces of meat or joints. It's just, we want to change movement and pain because that's what people care about for their lives. And we don't challenge that much why this is internally happening, because we know it happens, and the evidence supports that there are things that are happening that we still don't clearly know, even though we want to say we know, but we don't really exactly know. So what do we offer in FMMD based on available evidence? There are 4 pillars in FMMD. First of all, communicate properly. If we know that the manipulations, a big part of manipulations are, of its effects are based on the placebo effect, how we communicate things probably is much more important than what we say. Is how we say it, what changes, the narrative changes the results of the techniques that we do. Another thing that we show you is how to see movement. This is mostly based on SFMA, how to see movement. Because if we know how to see movement, or if we put some movement archetypes, we will be able to unequivocally to change tissues. Also, to feel tissues, we need to realize properly what are we touching, why are we touching that, in order to actually affect change, which is our main goal, to get people closer to what they love. So when I talk about communicating properly, knowing the pain mechanisms that are underlying the person's problem helps us a lot. We now know that there are 4 main pain mechanisms in most pain experience presentations of our patients: nociceptive, nociplastic, mixed, and neuropathic. Why is this so important? Because if we have a nociceptive presentation, the way we can help through manipulation will be communicated in a certain way that is different than if we have a person with a nociplastic kind of pain, where probably our movement-based manipulations are not going to be that helpful that if we are in a nociceptive phenotype. Also, in the neuropathic kind of pain, in a musculoskeletal condition, of course, the way we try to do things through manipulations will be communicated differently than in a nociceptive pain presentation or nociplastic pain presentation. So The way we communicate is fundamental in order to change movement and pain behaviors, because we know the placebo effect is huge in our manipulations in order to change things. What is the second pillar? How to see movement. There are some principles to see movement. If we see different schools in the world, like osteopathy, Mackenzie, Mulligan, SFMA, most of the big schools in the world, Czech school, they share something, and it's some first principles in order to see movement. And we would like to see how things look loaded or unloaded. One example would be someone going to touch his toes, or going to touch your toes in the floor. Active versus passive movements, taking parts away, putting parts in, and seeing consistent or inconsistent movements. How do we see this in practice? When I try to go touch my toes, if I don't touch my toes, but I touch my toes when I'm lying in a massage table, that cannot be a hamstrings problem. It's not possible, because the hamstrings are in the same position in here that if you are standing, but if you reach here your toes, that's not possible that the hamstrings can be the problem. So there's something else that it's obstaculizing the way that we get to movement. And here we can go on and on, okay? What's the third pillar? Feel tissue. In order to actually do a movement manipulation technique, we need to have three things in our heads, and if those three things happen, we are going to probably be able to change movement and pain. We have to position the patient properly. We as therapists have to position properly, and we have to position our hands properly in order to affect change. So how do we affect change? By actually presenting forces in a particular way in order to change movement and pain. So we believe in getting people moving pain-free, unleashing their movement potential as fast as possible with movement-based manipulations, delivered through a coaching model that encourages resilience and self-efficacy. So basically, movement as fast as possible. Yes, I'm trying to recheck all of these aspects. Movement as fast as possible without thinking that much in tissues, but in movement and pain, and a coaching model. So communication is a big pillar for FMMD. So how do we apply the 4 pillars in real life? We communicate properly depending on predominant pain mechanism. We see movement to address the area to manipulate common movement patterns. If I have lumbar pain, maybe I have to manipulate the thoracic area of the body. Maybe if I see movement properly, maybe I have lumbar pain, but I have to manipulate the ankle in order to change the lumbar pain and the movement behavior. Then we have to feel tissue, but not only the painful tissue, but the tissue that will help solve the patient problem. And finally, help people to get back to what they love with less pain. That's our main goal. Not changing a tissue, but to change a movement and a pain behavior. So this is somehow a critic to most of the models that are around that based on tissues. We have to remember that no one cares how much you know until they know how much we care. So that's our presentation in FMMD. I would like to thank you. That's my website, gonzakine.com, my social media. If you guys want to follow me or to see my work, it's mostly in Spanish, but if you want to get me any questions, in English, I will happily solve them. I will start sharing screen. That's
Thank
pretty
you so
much
much,
it.
Gonzalo Velasquez, for your wonderful presentation.
Thank you, Cherry, for letting me be here. I also want to, you guys don't know, all of you are saying this, but here in Chile, we had a change of time in the timeline. So I wasn't sure at what time I was presenting, and Chirag was desperate. Hey, you have to present in 5 minutes. And I was thinking I have to present in 1 more hour. So we are here, Chirag. It's all okay. We are all good. That's the whole thing about presenting in different parts of the world. We sometimes have these things happening, the time changing and all of that stuff. We are here. Thank you so much. And I don't bore you anymore. I hope you keep enjoying the day.
Yeah, thank you so much, Gonzalo, for giving your precious knowledge to all our participants, as well our chairperson, Dr. Manoj Malik, Dr. Devesh Seth, our treasurer, Dr. Saurabh Kumar, our organizing chairman, Dr. Abhijit Datta. One more announcement for all the participants, as well as our dignitaries, that Gonzalo will be coming to India in 2021. 22. He's saying
Yeah,
22.
yeah, you know.
Yeah, it can be 21 as well.
Maybe we have to work that out.
Yeah. And we'll be doing the fellowship course in functional manipulation for movement dysfunction soon, as soon as the COVID gets over. Hope so, you can say. So I would like to request Dr. Manoj Malik sir to say a few words about the presentation of Gonzalo Velasquez.
So, Dr. Gonzalo, it was an amazing presentation. And nowadays we are using manipulation for many things. Even we have started for migraine, and we are doing a study to know the efficacy of manipulation on anxiety, depression, effect of spinal manipulations. So it will be very great if you collaborate, if you come to India and you share your expertise. Then thanks for that amazing presentation. Thank you very much, Dr. Gonzalo.
Thank you for your kind words, Manoj.
Dr. Manoj, he had been in India twice.
Okay, I didn't know that.
Yeah, he was in India in 2019 and 2018 as well.
Okay, great.
Yeah.
So you are from a very beautiful country, and
and even he loves to come to India.
Yeah.
Yeah, for real. I'm hoping to get back soon.
Yeah. And I would like to request Dr. Devesh Seth to say a few words.
Yeah, thank you, Gonzalo. Thanks for the wonderful presentation. And it would be great if we can meet over, like when you come to India. And we would like to learn new things from you. Thank you for sparing time. Thank you so much.
You're welcome, Devesh. And just like I say to Chirag all the time, you guys think that I can teach to you, but probably Christian can say the same thing about us traveling the world teaching. We teaching are the ones that learn the most from you guys. So thank you for your kind words.
Yeah, that is the main thing. Christiana will also say the same, that we are also learning from you as well. So we would like to invite our next speaker, Dr. Christiana Villela, is a professor, BSc, PT, diploma in osteopathy, as well as PhD. Is a university professor for manual therapies and president of the OsteoPro, Italian Association of Professional Osteopaths, and a creator of facial floss method. And also he is the teacher for Europe for hands pro technique. And in this summit, he is our co-pattern as well. So we would like to request Dr. Saurabh to welcome him as well. He is the president of OsteoPro, the association which is academic partner of our summit, and Also, he is the member of European Register of Therapists. Because of him only, we got the accreditation from both associations.
Welcome, Dr. Christian Velala. We'd like to welcome you on behalf of our academy, as well as from India. All the Indian people and from our participants from abroad as well are waiting for your lecture. I sincerely hope that it will be great for all of us to get the latest of physiotherapy knowledge from you and around the world. So you can continue, sir. Please go ahead with your presentation.
Yeah, hello, and thank you for inviting me. I will share my presentation, just a moment. Okay. So the topic for today, we'll present you is the fascial floss. It's a compression band therapy. And compared to the sciatic pain, it's maybe a pain that all of us know about that. Actually, about 5 people, 4 of them have sciatic pain or back pain, and fascial floss can be very helpful for us to reduce pain, to increase mobility, and to help us to go over this pain. That's okay. You already present me, and I will go on maybe with the lesson because I'm more about the technique and more about the method, not about me. I just always say I'm a messenger and not the inventor. I just translate or bring the things I discover by trying and practicing every day to the person. I'm very happy to compare it with other methods or to have possibility to give my ideas of my things that I discover to other and to have a feedback from them. So I invite you to use the method and give me feedbacks. The things we have to say that it's not only my idea, but it was an idea by Kelly Starrett. This a doctor, and he invented in 2015. It was called voodoo flossing because it was like a really astonishing and very impressive results that we have when we apply this overlapping latex tape. And after he used it, especially after triathlons, and after triathlon athletes, they have very pain in the legs or in all over the body. And he tried to reduce this pain after these races, and he used it to improve the health and the comeback of the athletes to the performance and to the races. And he saw that the people they use voodoo flossing was like wow, astonishing. They say, wow, that's an incredible effect. So he invented this name voodoo flossing like something magic. I took his idea and I tried to change or add some things that I have after 10 years of fascia studying. And so I tried to add some manual therapies. I add some movements, I add some techniques, I add some things that we have and we can use in a manual therapy. Actually, with this technique, we can create restriction. We create restriction of the movement in the different part of the body. And the idea is to create restriction for breaking or reduce the adhesion of the myofascial nodules like trigger points or other restriction we have in our bodies. And thanks to fascial floss, we can execute movements in different directions, speeds, and the therapist can use different techniques. And he used a method that's called myofascial sliding. That means that he do restriction, he block the skin and the subfascial structure, and using the mobility of the articulation, he produces a sliding between all these different tissue, and this tissue are sliding one direction. Meantime, the bone or the articulation is sliding in the other direction. These different directions during these movements and different techniques help us to break this this adhesion, and this structure is sliding one direction or the other, and give us then more effects than can one expect. The benefits of the fascial floss are very, it's not like 5, but there are a lot, but I try to resume it for you. And the first thing we have after this treatment is we can increase the mobility and the movement of the articulation. Means after an injury or after like a distortion, I can use this to bring back the articulation, use the movement we have before. We have different study as well published at PubMed and PubMed, where we produce or we try to use the fascial floss to increase mobility after treatments about operation or surgical application or intervention on knees, on ankles, or shoulders and elbows. And after years, about 20 years after, when we think that all this structure have been stocked and all the adhesion had blocked the articulation, we have about 20 until 35% of better movement after the application of the fascial floss. That gives a really chance to try to use it after injuries, but not only in the short period, like 6 months, but after years, we can have other good result as well. We can improve muscle mobility. I use it, for example, when I, next week I will be in Berlin for the marathon, and I have some athletes there running for the marathon. And I use this technique to warm up the muscles because they give us the chance as well to wrap the muscle and to heat it, so prepare it better for a performance. Another benefit is decrease the pain. With the compression we have from the structure, that means the skin and the nociceptor we have in the substructure, struttura subcutanea, under the skin, the structure under the skin. So we create a compression of the nociceptors, so the brain cannot receive the information from the pain area. So actually the people or the articulation can move normally, like no pain. And that's it's very important when we treat pain, because it's important for us to break the constant information that the articulation or the pain area is giving to the brain. So for us, it's important to create these windows where the patient has no pain. They say, wow, it's going better. And this helps us to give us the possibility to increase the healing movement, healing structure and healing procedure that the body will go, because until they have pain, the people are just stopping, they just relax, they just say, no, I have pain and I have to move. But when you take them the pain, they say, no, I have to go back to movement, to go back to healthy situation. We can as well accelerate the functional recovery after like injuries, muscle injuries and articulation injuries. And we can as well work on immediate recovery in sport traumatology. For example, we have a lot of football player here in soccer play in Italy, and we use it a lot during football plays that we have like distortion. We apply fascial floss, all the information, pain, mobility, and recovery is accelerating. So some people can go back to the game immediately, or at least in some days. So the benefits are a lot. So fascial floss is like a latex tube. I show you here in real. Here we have different colors and different size. Usually we use the small size because it's easier to handle expression in the beginning. For using fascial floss, I always ask to my students to have a good manuality of bandage, so to do normal bandages, and then you can go on fascial floss with no, we can go faster in the application. What is the fascia tissue? Just short, because I think everyone knows about that. It's just like a connective tissue that covers all our body. It's inside, it's outside, and it's connecting everything. And what is the mechanism? What are the fascia doing? They help us to do the metabolic exchange. That's very important for the recovery part. when we try to give to the cells some new information, some new nutrition, and to bring away all the things that are stuck in there. Broke this nutrition procedure, but as well we have to do some exchange. We have to bring new information, and we bring some new information as well from the immune system, because we can stimulate as well the immune system. We can work on the skin. We have the thermoregulation support by the muscle, but as well produced by the fascia tissue. We have some change of the fluids, not only the blood or other, but we have as well this liquidor lacunaris, the liquid between the different fascia structures. And we have as well the possibility to increase or to help to slide the nerves, blood, and lymphatic gangs, so all the structure can move faster and in proper way. We can use fascia floss in different areas. We use it as prevention, like I told you before. Then I can preheat or heat our muscles and do a proper warm up, so the muscles will maybe. It's always this, there is not insurance, but actually when you have a good warm up, the muscle will perform better and the possibility of an injury is reduced. We can use it as first aid, like first answer to an injury or something like that, or we can use it like a treatment. When we use it like a treatment as a therapist, we can connect it to other tissue or to other technique we know. We can, for example, use vibration, stimulation, cupping, and all the techniques and mix it up with fascial floss to increase the effects. So that's just to put some pictures to see how we can see. We can apply it on the shoulder for the rhizarthrosis at the thumb. We can apply it at the muscle in the leg. And after we have, I did some videos for you to see exactly how we apply it. But before we do that, we have to see some elements, okay? When we apply fascial floss, we can connect it to different techniques. I can do yoga, I can do stretching, I can do isotonic exercise, I can do isometric exercise, I can work on muscle dynamics and articulation and biomechanics. I can do plyometric exercise. I can do motor coordination, proprioception, and sensomotoric. That means that all these areas, they can be improved by applying the fascial floss on the articulation or on the part I want to increase the effects and the benefits. So actually there is no limit to, or no places where we cannot use the fascial floss. So we go on, and that's the basics. You can forget all the other things, but these 3 pages I show you now, they are the basics of the fascial floss, of the fascia application, because we have to respect these rules or this indication to have the proper and the best results. At the beginning, as the application is always applied from distal to proximal, always from the periphery to the center. There are some expectations where we use it in a different way, but usually in the 90% of the cases, they are distal to proximal. And sometimes we can, like Gonzalez said before, we can listen, we can test the tissue and we can see if there are facilitation direction, or we can see, we'll listen, or we can interrogate the fascia or the tissue to evaluate to see if we have to apply the fascia in a different direction. But sometimes we have used it, we have get used of that. So it's not so easy when we start with the manual therapy. So in case I say distal to proximal, the application times approximately 2 until 5 minutes. We have to respect them until 5 minutes, not more, because we have just a restriction of the peripheral and superior vascular system, but actually we can have some problems if we applied too much. You can apply it 3 times, and we have always wait between 2 and 3 minutes between one application and the other application. Then the tension. The tension of the bandage can be between 50 and 90. It's depending on the district. Always when we do application for lymphatic application or first aid application, the tension will be only 50. That's very soft, okay? Then we do the second application, the third application, when we increase the tension, but at the beginning, just soft. The tension can be until 90 in the tension in the joint area, in the articulation area, but we have just bones and not so much muscles. And in the muscle area, we have between 50 and 80% of the tension. Always think about that if you have a serious problem or we have a important problem, we always start less and go a little bit higher, and always ask the patients if it's okay or it's too much, okay? But usually that's the rules. How is the area? Area is the first application of the first round is 100% cover. That is just the base for our bandage. And then we go on and cover it at 50 or 70% depending the area we are covering. So if we are covering a muscle area, we just cover the bandages 50%. If you go after over joints articulation, we have to cover it until 70, because when we have to do the movement with the articulation, I'll show you after that the video. It's sometimes the articulation is living out and the bandage is falling down. So it's very important to cover it properly. Okay. Always we have to keep the articulation and joint in a relaxed and the physiological position. So we have no restriction, we have no tension. Okay. So sciatica, just 2 slides. Sciatica is the longest nerve in our body, and it's goes from the back until our feet. And with the terms we use in sciatica pain, we always speak about a lot of different pains and symptoms. They are affecting this long nerve. So before we apply fascial floss, we have to do some differential diagnostic to find out if it's a real sciatica or is it just a compression from the piriformis or something else. But the differential diagnostic is the base for every manual treatment. So actually, we have to do that before. We have no surgical treatment for the sciatica pain, and usually we do rest, we do apply heat or ice therapy, we take some medications, usually anti-inflammatories and medications. We do some physical and exercise, we do physical therapy, and we use sometimes pain relievers. If we just think about fascial floss, we can imagine that we have in this description for no surgical treatment, we have a lot of things that are done by fascial floss, because we have pain relievers, that's a natural pain relievers. We have exercise, we have physical therapy, we have something like a heating, we heat on the part, and the rest as well. But we have a lot of information that we are giving just with one bandage. It's incredible. So fascial floss application. Now we just show you the application of an ankle. I hope the video is running. Yeah, you see that right video? Okay, that's the application of the ankle. We do the cover of 100%, and then we cover the bandage of 70% and going on. Usually do 3 lines, and then we do the first around the ankle, go back to the feet, or the foot, okay, and then come up again and do some like crossing here to increase.
I think network issue is there. Everyone is having the same issue.
Yes, same thing happened here.
Yes.
Manoj sir, you are having the same issue.
Yeah, I think some network issues there, sir. That's why it has stopped. The presentation has stopped.
Yeah, okay. So yeah, Christiana has again joined.
I'm here again.
Yeah, you can present. You can start again sharing your screen.
Yeah, sorry.
Okay, no issues for
So
that. Yeah.
that was the ankle application. Then I show you the calf application. Okay. The calf application, we have the person in a standing position. We start over our ankle and we go around. Prevent that with fascia. Sorry again.
I think Christiana, your video has some issues, or your
Yeah.
network is having an issue.
Okay, you see me now?
Yeah.
Okay, that's the calf. So we go on. Okay, the knee. For the knee, we have the same as the ankle. We start in the tuberous tibialis, go around the knee. The covering here is about 70%, and the tension will be about 90%. Like I told before, we have a swelling or edematous knee, the tension will be less, but otherwise I will pull a lot because the tension will be very strong around the knee. I can handle the tension around the rotula and to see that I'm not compressing too much, but actually when I use it, I try to compress all the knee, and in this case, I give a good tension. Okay, and then I show you the leg application. The leg application will be a little bit more difficult because we use two bandages and one bandage is containing the other. I'll show you now the leg. I start around the ankle and I use 2 or 3, I could remember. Okay, up. Here the tension will be 50. Okay, then if we have some patient that will give us some help, it's good, but otherwise we have to start again. Now we are in the knee area. The tension will be more and the covering will be less. So we actually have 70% of covering. Tension will be more. Right, okay. And I finish here. Usually I use the third one to go up until the basin to cover all the leg. I do this, I perform this technique in case of the triathlete, and I cover all to the legs and let them do some exercise and do some action. As I told you before, I can do some manual therapy or I can do some movement, some flexion of the knee, or as well I can perform some osteopathic treatments, some thrusts or some adjustment. I can perform every technique I know from McKinsey to everything. And I have a good application of the fascial floss for sciatic pain if I work in the different area and work sectoral. So I work on the calf, for example, when I have pain in my calf. I work on my leg when I have pain in my leg, or I can do bandages like I showed you before to cover all the leg and do then the technique I know as well. I show you here some techniques, or no, I show you before I called it the medical effects of the fascial floss. We have a myofascial release. We destroy the crosslinks I told you before. That was discovered by Stecco. It's a research doctor here in Italy. Then we can improve the joint and the movement of the RUM. We can stimulate the mechanoreceptors. We can reduce edema, swelling, and the lymphatic system. We can as well promote and facilitate the sliding of muscles, tendon, ligaments, and nerves. We can increase the circulation and so have a reactive hyperthemia. We have as well something like called wash effect. When I compress something and then I put away the bandage, a lot of blood is coming. So all the area will be overflowed by new blood, and the healing mechanism can start again. And as well, we have something like a gait control. We can reduce the pain by applying the fascial floss. The combination with classic techniques like told you before, we can do some stretch, okay? That's the normal application of the stretch for the sciatic pain. When I apply the fascial floss, I can increase the mechanism of the stretching. And as well, if I put just like I told you before, the fascia on the calf, I can increase the compression information in the calf. So I can work very specific on different districts and different areas. As well, I can do some yoga. I as well yoga teacher, and sometimes some practice are arriving to the studio, they're asking me, they have some pain and so, and then I decide just to apply the fascial floss and do some exercise. We can do for example, the child pose. We can do as well the downward facing dog, Adho Mukha Svanasana, or we can do as well the cat or the cow pose. We can do the pigeon pose. That's very important for our sciatic pain. It's maybe the most common position for the sciatic pain. Or we can do the triangle pose. There are poses, they are working all on the sciatic pain. If I apply the fascial floss, I increase the effects of this position. And at last, we can do a lot of manual therapy. I just took some because they are a lot. We can do just a compression, okay? And if I do compression through my bandage, through my fascial floss, I can use the fascial floss to increase the compression. So I will just use less work of my muscles, so less force to press it. So I can save my powers and save my muscles for the whole day, because if I treat a lot of people, it's very important to save the energies. Then we can do some piriformis stretch. I just apply the fascial floss on the piriformis and the piriform area, and then have a specific stretch just for the piriforms. I can do the calf stretch. I can do the one knee to the chest when I just bend the knee and bring it to the chest. I can do double knee chest stress. I can do as well the leg straight stretch, like we perform to testing the nerve. And as well, we can do some aerobic exercise. I usually after the first part of the sciatic pain, when the part of sciatic pain will reduce, I try to increase the oxygen the oxygenation of the part. So I will apply fascial floss, do some exercise, really put away the fascial floss, repeat the exercise. So this part will really work better, because they get more information. They get the information of the fascial floss, of the compression. New blood will arrive, new oxygen will arrive. That helps us really to do a better work on this area. Okay, I hope you can profit from my presentation. I hope you will maybe find some indication or some helps for your treatments or for your daily adventure in the manual therapy. We can use fascial floss. We can use many instruments. I'm really happy to have discovered this fascial floss because I'm using now since about 6 or 7 years. And every time I show it to my students, they are very happy because they say, wow, it's like something magic. It's the people are standing up after an injury, 5-6 year ankle problems. You apply just one time the fascial floss and they stand up, they run, and they say, oh, there's like something new, no? Here we have my my address. You find me on Instagram with Fascia Floss. We have internet sites for all the movement and all the techniques we are performing by movement, because I believe movement is the better solution for all the pains. And as well on Facebook with Christian Villela Okinawa. And it's Japanese, but it's nothing. I'm not Japanese, I'm Italian. And we have as well Osteopathia Alto Adige. That's my internet site of the studio here in Italy. And if you want to write me, you're welcome. And you can contact us through OsteoPro or European Register of Therapists as well. And I'm very happy to all the ideas, all the questions, and all the things you want to tell me. I'm very, very happy.
Thank you, Christiana, for your wonderful presentation. And actually, we are streaming this live on the Townscript platform. So it takes around 15 seconds to be over there. So participants will write their question on that platform, and I'll ask that question from you. And you can reply over here. Okay,
fine. I'm sorry for the interruption of the connection, but it's always like that. It's if you listen,
no issues for that. Actually,
the next time we will perform it in India.
Can we ask our panelists also, our chairperson sir and co-chairperson sir, if they have any questions regarding it, they can ask before the participants are typing their questions on the town hall.
Yeah, for sure. Dr. Manoj, you can ask, and Dr. Devesh also you can ask. And also we have got one question as well. This question is for Christiana. How long do we apply facial floss tape for?
I wrote it between 2 and 5 minutes as maximum. I applied 2 minutes for normal people and 5 minutes if I apply it at sportive or sport practicants, because they have a better sensation of their body and they can say, no, stop, there is too much. And we applied maximum 3 times.
Okay, thank you. Dr. Manoj, you can ask.
Dr. Christian, thank you for delivering such a wonderful lecture. I just want to ask that I have never heard about this technique. I think this is one of the latest techniques. Do we have any evidence about it, like any evidence-based, like some article or some journal who supports all these things? Some
research? On PubMed, if you write fascial floss or flossing band, you will find a lot of them.
Okay, thank you.
You're welcome.
And also, I think that the last slide, you have written thank you in various languages. Yeah. So you accept our thank you in Hindi, Dhanyavad. Thank you for.
I just speak 6 languages, but I will start learning as well your languages.
Yeah, we'll invite him to India and I will tell him all the, Indian languages. India has around 40 languages.
Okay, that's it. I stop with 6, maybe.
Yeah, for surely. When you come to India, you will stop all those 6 languages and you will learn Hindi and Haryanvi the most.
I already visited India. I was in Rajasthan, in Kolkata, in Kerala, and in New Delhi, in Varanasi, and I love it very much. So I will come back when the COVID will be maybe.
Oh, that's so great. That's so great. Okay, that's so great. So, Dr. Devesh?
Just one question, Dr. Christian. How do you decide on the tension part? Like where to give how much tension while flossing?
Okay, it's depending which area I'm working on. If I work on muscles, the tension will be between 50 and maximum 80% of the tension. If I pull the rubber band, the tension, complete tension will be 150. So 50, it's like just covering the area, and pulling a little bit, that's 50%. The best thing is to try it on our own body to see how much the tension will be. So I always ask to my patients and ask as well as my students to do the first apply of the fascial floss on our arm to see how much to have to pull it. But actually on soft area, it will be maximum 80%. on ankles, on articulation, the tension will be very, very strong because we have to stop the articulation and use the stopping by improve all the Golgi receptors, as well reduce the nociceptor transmission to the brain, and as well to permit the myofascial sliding of the structure that are very, are very tight. No? Like we think on the ankle, all this tissue is very small between the bone, between the skin, so the tension will be very hard to reach the deepness of the tension, the deepness of the tissue.
Yeah, facial floss works very good because I'm practicing from 2018, and I think
Okay.
Dr. Saurabh, you are also practicing from 2019 as well.
It works amazing.
Okay.
Thank you so much, Dr. Krishna.
You're welcome. Thank you.
So this Ortho Colloquium comes to an end as well, and successfully we have completed the day 1 of our second International Web Physio Summit 2021, organized by Academy of Exercise Health and Therapy in collaboration with Assam Downtown University as an academic partner and European Register of Therapists and Osteopro and Osteopathy Association from Milan, Italy. So today we had 4 speakers, and Dr. Christina is our co-patron of this summit as well. We would like to wholeheartedly thank you to Dr. Christina for giving the permission from Osteopro as well as for European Register of Therapists as an academic partner of this summit. This is all because of Christina. So I would like to request Dr. Saurabh and Dr. Abhishek to thank Dr. Christina for the academic view as well and for being the co-patron of this summit as well.
Firstly, thank you so much, sir, for accepting our greetings to be a part of Academy of Exercise Health and Therapy. And we would like to thanks for our upcoming events in future as well as now. And today's it was a wonderful session presented by you, totally new things coming from your side, like a sciatic pain can be treated by floss. And really it will be hopeful for me. And I'll definitely use in sciatic pain because I just use for the delayed onset of muscle soreness or to increase the range of motion of the joint or just for the athletic persons to release their pain. But definitely I use tomorrow on the sciatic pain patients and update you soon. Thank you so much.
You're welcome.
Actually, Christina, we have got one more question.
Yeah.
You mentioned that we can do the floss max for 3 times. Can also mention the time frame, like 3 times a month or a week?
That's usually 3 times for one session when the person are coming to our studio. Then I usually wait 2 until 4 days, depending on the type of trauma or the type of injuries we have. And then we apply it in the same week. If just we have an acute situation, we can apply again. Otherwise, I wait until 7 days to do another application. But in the same time, when they came to our studio, I do 3 applications. Usually how I practice it, I do the first application, then I do all the treatments, all the additional treatments I have to do. I do a second application. Okay, so I would wait longer than 5 minutes. And then at the end, to give the final information to create this effect I call the wow effect, when they say, wow, that's great. I do it until we are leaving my studio, just to give the final information. And the technique, I can do it first time, wait 2 minutes, second time, wait 2 minutes, third time, and just go on with my treatment.
Any more questions if anybody wants to ask? Dr. Devesh, Dr. Manoj, Dr. Saurabh?
No more questions from my side.
Dr. Saurabh?
No question from my side either.
Okay, just wait for one minute more so that participant can ask if anybody is having any questions. So Christiana, when are you
No, I
planning
think
to?
he has explained it so well. I have given more.
Okay, so Christiana, when are you planning to come to India?
When the possibility of flying is becoming better and the COVID will be give us the chance to travel more easy and more fast.
Yeah, because participants are waiting over here in India for your Hands Pro course as well.
Yeah, I know I got some communication to the students from the last year. They communicate with me by Facebook, and they're inviting me all over India to come there and do some lessons. And I'm sorry, because for me, I will start tomorrow. If it's not by plane, I will come by bike. Okay, but as soon as possible, I will buy you and exchange our knowledge, because I've like told Gonzalez before, the way to you are helping us to connect all our techniques will help us to increase our knowledge and to help more people and help them to be more healthy and be good and be okay like that. I appreciate the things you do last year, and today this year is better, and we hope we do better every year.
Yeah, thank you so much. And I would like to request Dr. Manoj and Dr. Devesh to say a last few words.
Thanks, Dr. Christian, for presenting this amazing facial flows technique, and all the sessions were very wonderful. I hope everybody benefited from this, and thanks a lot for inviting me in this amazing session of series of sessions. Thank you.
Dr. Devesh.
Thank you, Dr. Christian, and all the best to the team of Dr. Chirag. And it was a wonderful session, lots of learning, lots of new things. And thank you, Dr. Manoj. Thanks once again. It was
Thank you.
wonderful time spent with you. Thank you so much, and all the best for further sessions.
Thank you, sir. I would like to request Dr. Saurabh to give vote of thanks and to end this day first, as well as to end this colloquium, because Dr. Saurabh was the speaker as well in this colloquium. I think Dr. Saurabh, you have to unmute yourself. Okay. Dr. Saurabh, unmute yourself. Again, I think Dr. Saurabh is having an internet connection. Dr. Saurabh, am I audible to you? Sir, unmute yourself. Dr. Saurabh, unmute yourself. Dr. Saurabh is saying something, I think, but not able to unmute himself. Just wait for one more second, because Dr. Saurabh is having some error. So he's rejoining in 1 minute only. Yeah.
I think now I am audible, sir.
Yeah, yes, sir. Please tell.
Thank you so much for giving all of us this opportunity to be a part of the summit. Thank you so much, sir. And Dr. Manoj Malik, presence was so precious. He's just like a mentor to me. He has been
I think again, Dr. Saurabh is facing some internet connection issue.
will be better, getting better day by day for you. Thank you so much. Thanks again, co-chairperson, Dr. Chirag, Dr. Abhishek. Thank you so much from my side, from our academy, to all of you. And we even better, getting better day by day. Thank you so much.
And I would like to request, now last but not the least, I would like to request all the participants to join tomorrow at 10 a.m. That will be the second day of this colloquium. Cardio colloquium will be there from 10 a.m. to 12. And afterwards, PEDS colloquium will be 3 p.m. to 4 p.m. And afterwards, last but not the least, 5 p.m. to 7 p.m. will be the sports colloquium. So stay tuned, join us. Thank you, everyone. Thank you.
Okay, bye everyone.
Bye, sir. Bye. Thank you.
Thank
Bye.
you.
Bye bye, sir. Thank you so much.